Good morning, distinguished guests, respected faculty members, esteemed colleagues, and dear students. It is my privilege to welcome you all to day 2 of the IAPSM UP UK Conference 2025. After an enriching first day filled with insightful discussions and meaningful exchanges, we gather again with renewed enthusiasm to delve deeper into this year's theme, which is One Health. The concept of One Health reminds us of a simple yet profound truth: the health of humans, animals, and our environment is inseparable. Whether we consider emerging infectious diseases, antimicrobial resistance, climate driven health threats, or food safety, each challenge crosses the boundaries of sectors and disciplines. And therefore, the solutions we seek must also be collaborative, interconnected, and holistic. I encourage each one of you to engage actively, ask questions, share experiences, challenge assumptions, and explore opportunities for future collaboration. Conferences like this are not only about knowledge exchange but also about building a shared vision and nurturing a community committed to transformative change. On behalf of the organizing committee, I thank you for your presence, your dedication, and your commitment to strengthening the public health landscape of our region. Let us move forward with the curiosity, compassion, and a collective determination to make the One Health approach a reality in our work and our world. With that, I formally welcome you all to day 2 of the IAPSM UP UK Conference 2025. Let's begin today's sessions with energy, purpose, and hope. Let us begin with the first session for the day. The topic for this session is medical education digitalization. This digital imperative is particularly acute for us as it directly impacts our ability to scale knowledge and care across diverse and often resource limited populations. Digitalization is not just about convenience, it is about the equity, access, and efficiency. It promises to transform how we train students to conduct epidemiological surveillance, manage outbreak response during geospatial data, and deliver preventive healthcare during remote platforms. Therefore, our focus moving forward must be on actively reconstructing our curriculum to ensure every graduating student is not just clinically competent but digitally empowered, ready to leverage technology to serve the community on an unprecedented scale. So, the chairpersons for us for this session are Dr. Tanveer Bano ma'am, Professor Community Medicine, LLRM Medical College, Meerut. Sh- She has 55 research papers in national and international journals, attended 50 plus conferences and workshops, fellow IAPSM UP UK Chapter 2023, recipient of Meerut Ratan Award 2013, state observer and medical trainer for BSPM, ECP, RTI, CDR, EVM, and IMNCI. Ma'am, please take your seat on the dais. Our next chairperson for the day and the session is Professor Dr. Reema Kumari Ma'am. She's a professor community medicine and public health KGMU Lucknow, MBBS MD KGMU and CHCWM IGNU. She has 23 plus years of teaching experience. She has guided numerous MD and PhD theses. She has 68 plus publications and involvement in 17 plus research projects. She is the contributor to several book chapters, including Holistic IVF, IUI, and Garb Sanskar. Ma'am, please come and take your seat on the dais. जी मैम। पूरा नाम क्या है मैम? मैम इनका बायो मैम अपने तो कल हो चुका है ना इनका। व्हाट इज प्रोफेसर? हाँ मैम, ये प्रिंसिपल प्रिंसिपल एरा। Okay, I would now like to request our next chairperson for this session, Dr. Jamal Masood sir, who is the principal in Eras Medical College. So please come over the dais and take your seat. Sir, obviously, sir, send it to me. So our next chairperson for the session is Dr. Jamal Masood sir, who is currently principal and chief medical superintendent in Eras Lucknow Medical College and Hospital. Sir is the chairperson of PhD Cell, Era University in Lucknow. He is the former HOD, Department of Community Medicine and Public Health in KGMU, Lucknow. Former Joint Director and Staff Officer to DG Family Welfare, Government of Uttar Pradesh. Implemented RCH1 program in the state of Uttar Pradesh. He is the member of a state level AEFI committee, Uttar Pradesh Advisory Committee of Council of Science and Technology. Sir is the national trainer and the master trainer of national programs of RBSK, STI, RTI, NVB, DCP, IDSP, HSS, and NPCCHH. Organized 71 workshops and CME programs. He is ex-officer in charge and established Suraksha Clinic in King George's Medical University, Lucknow. He is the ex-nodal officer and established Yellow Fever Vaccination Center in KGMU, Lucknow. He was awarded Excellent Service Award in KGMU, Lucknow. Sir is also a reviewer of WHO Southeast Asia Journal of Public Health. So now may I please request you to please come over the dais and take your seat. Next, our speakers for this session. Our first speaker is Dr. Ruby Malhotra, ma'am. She is the professor and head of Department of Ophthalmology in Integral University. She has 50 plus publications in national and international indexed journals. She is the co editor of the book Insight into Diabetic Eye. She is the recipient of FOTI 2024 Award, UPSOS Award, and Dr. P. Avasthi Award and Dronacharya Samman. She has guided 20 plus MS ophthalmology theses as a guide and co-guide. She is coordinator of Medical Education Unit of our Integral Institute of Medical Sciences and Research. She is also the member of UPSOS, AIOS, ACOIN, DOS, and AOS. May I now request ma'am to please come over the dais.
Hello. So, a very pleasant, fresh, warm good morning to all the delegates, to respected chairpersons who are sitting on the dais, as well as dear students. I'm supposed to talk about medical education unit and medical education and digitalization, not a very, very core topic for my specialty, but because of having worked in the medical education unit for a few years, I've been the MU coordinator for the last 4 years at my institute. So I happen to be working in close quarter with people from all speciality. So learning quite a bit. I would start with just a little introduction of the importance of digitalization, the importance of virtual learning by an example which happened today with me, today itself. Palak, my presentation needs to be displayed. So I would start with just a little anecdote that I have to tell. Today in the morning, like all of us, as you know, were a little busy with the conference and the making up and the management of the conference. So I happened to prepare my session that I have to present day before yesterday. And yesterday I made the final changes, downloaded on my pen drive. And this, I think, was the first time when I just did not happen to take my laptop with me. So here I come. Last moment, when I just switched on my car, I was thinking, should I take my go up? I'm staying on the eighth floor. So should I go again and bring my laptop? That lackadaisical attitude and procrastination inside me, that made me think, chalo chodo, pen drive mein to hai hi na, हो जाएगा. Because never I had a glitch with a pen drive, so हो जाएगा करके ऊपर नहीं गए. अब here I reach integral 9:15. I'm here in time for my session. Nobody's here. Chalo start करा लो. So, ma'am, some meeting and let a few delegates come. I said, okay, I'll just download my session and we'll wait for all the respected dignitaries. चलो ठीक. वहां पहुंचे, पीछे बैक स्टेज सेशन को जो था पीडी लगाई, पीडी लगा के बंदे ने डाउनलोड किया. वन और टू आई थिंक वर देयर ऑल्सो व्हेन आई जस्ट टोल्ड देम ऑल्सो. एंड जैसे ही वो खुला तो फर्स्ट स्लाइड, इट डिड नॉट हैव माय नेम, दिस वन. So I had downloaded the image from internet and I had clicked and put my name and all. So I said, what is it? It does not have my name. Then I go on scrolling and I see it's just random pictures and it is just random data. This is not my presentation. I guess what's wrong? Not a very digital savvy person. Just as NMC asks all of us to be a lifelong learner, I'm into that road of learning about digital technology. So what to do? I said, I don't know why and how I got an unedited presentation. Please look into it. Anas, our AV Tech. I said, Anas, just go through the PD again. You will see my final copy. He said, no, ma'am, there is only one thing. And then I remember, yes, I had freed all the data and I had deleted rest of the things. Let's see what happens. Now my mind is running what to do. Here I was expecting कि 5-10 मिनट में स्टार्ट हो जाएगा सेशन और हम ही ने बोला है 10 मिनट में करो और हमारे पास तो है ही नहीं. एंड माई हाउस इज अबाउट 45 minutes away from where I stay. So I have two options. Either I present the unedited one, number one, or I present extempore, which we can do because we are so used to teaching students. So now we are open with just talking about a lot of things, even if we do not have a slide. And the third option was, for a spur of a moment, I had no third option. The third option was, should I go back? That will take me almost 2 hours to come back, which is senseless once again. Suddenly I realized today is Sunday and my husband is at home and he is more digital savvy than most of the AV techs around, into computers, into digitalization, into everything. I said, why not use him? Most of the time, utilize his strengths. That's what we are supposed to do. I just gave him a call. I said, just open my laptop, take my passcode, and there is one presentation you'll see on the desktop. Just send it to me on WhatsApp or mail, wherever you can. He opened, just 2 minutes he took. He opened that. He had this Now he says there are two. Which one to send? I said, first click open. That's the mistake I did because all through I was clueless. I said, I have saved only one copy. How come I got this one which was not edited? Now I get to know through him there are two. Which one do you need me to send? I said, just open and see the one in which my name is written on the first slide. Just share that slide, that presentation with me on WhatsApp or mail, wherever you can. And voila, 2 minutes, I get that presentation with me through WhatsApp. I give to Anas, and here I am standing with the presentation. This, if it would have happened about 20 years back, when we were into slides, when we were into OHP presentations, I'm sure this would not have happened. So, two things. One, I learned today we cannot survive without digitalization. And number two, always to carry a laptop and have a second option when, because today it was my lucky day, I had Sunday. What if it was another working day and my husband was operating in the OT in his Apollo hospital on his plastic surgery cases? So, how would I have asked him? Nobody in my home, apart from him, digital savvy, surely not my home caretaker, as we call them these days, or the people who take care of our household chores. So, she would not have been able to help me. So, these two learnings for today. Now I'll start with my presentation of digitalization, just laying stress on the fact how these days digitalization can be used for not only our advantage, but the most important bearers who are here today, or rather the bearers who we are dealing with every day, that is our dear students. So, medical education and digitalization, it is the backbone of medical education, as all of us know, is the backbone of healthcare, because that is how and where our students start the journey of becoming proficient doctors, proficient healthcare takers, skilled surgeons. As it is said, एक बहुत important saying है, अब लखनऊ में है तो एक तो जैसे कल the organizing chairperson रिस्पेक्टेड प्रोफेसर डॉक्टर बिलाल ने कहा, मुस्कुराइए आप लखनऊ में हैं. सो एक ये, और दूसरा ये, एक दो लाइनें तो बनती हैं. जैसे हमारी ऑनरेबल चांसलर मैम ने कल इतनी अच्छी अच्छी लाइनें बताई, तो एक आध लाइन तो बनती है कि आगाज अच्छा होगा तो अंजाम अच्छा होना ही है. सो बेसिकली इफ वी स्टार्ट द जर्नी ऑफ आवर स्टूडेंट्स in a disciplined manner, in a friendly manner, in a proper manner, exposing them to all the realms of medical education and all the types of teaching learning methodologies, that would help them in getting groomed into the doctors, the specialist that NMC wants them to be. The future of tomorrow, the Indian medical graduates, as they are called, who should be specialized in being good clinicians, in being good communicators, in being good professionals, in being good lifelong learners, and also researchers. So, this is how it is the backbone of healthcare, and all of us are now aware that because NMC introduced in 2019 the competency based medical education. So, the medical education has undergone revolutionary changes in the last 6 years. We are still in the process of learning. We as mentors, we as their facilitators, the teacher word is being asked not to be used very frequently. The student word is being asked not to be used very frequently. So, the learners and the mentors, the facilitators, is what the medical education wants to groom. Not, and the fact of the matter is that right now the grooming is more on the facilitator rather than the learner. We are the ones, as their mentors, as facilitators, who are undergoing workshops, the basic course medical education workshop, the curriculum implementation workshops, the advanced course medical education workshops, the FIMER workshops, all of these workshops, the purpose of these workshops is that it is helping us groom ourselves to be able to take care of the latest teaching learning methodologies which are being introduced into our medical education system. So the digitalization is reshaping how the doctors learn and how the doctors are supposed to practice their skills, harness their skills, not only during their training period, but also later on in life. And the objective of digitalization is to explore the tools that are available around us. So many of them. Every time I go to my class and I tell to my learners who are there sitting, a bunch of them, you are so lucky. Actually, you are so lucky to have everything in your hand. In our days, if we had to search for something, I'm a product, I did my post graduation from LLRM Medical College, Meerut. So if we were supposed to do research in thesis, for our thesis work, I still remember our head of the department used to send us to New Delhi. NML, or the National Medical Library over there in New Delhi, just next to All India Institute of Medical Sciences, was our regular destination almost every second weekend, because we did not have enough of journals. We did not have enough of reading material in our libraries, but the NML had a whole plethora of it, and we were allowed at a very substantial student rate to get it photocopied. So that was what was, and those were the days when the thesis research work was done very, very ethically. No plagiarism. That is what I remember. Hopefully, these days also the students, but because of all of these digitalizations and the latest tools available, a lot of things are happening around us. So, those were the days. So, I tell my students, you're so lucky. You just have to maybe get yourself subscribed with just a few hundred rupees, and sometimes not even that, and you have so much of data available with you, you have so much of learning material available with you in the form of your AI tools, in the form of YouTubes, in the form of videos. Such beautiful lectures, such beautiful videos of surgeries, of procedures of which we had just read in the books, and we used to take hours and hours and hours to get our brain to understand how actually if this is done. लिड में कोई सर्जरी होनी है, ये मसल यहां से काटनी है और इस मसल को यहां से रिसेक्शन करना है. Being a student, first and foremost, it used to be so difficult to visualize it in our mind, and second, even more difficult to visualize complicated situations and imagine ourselves doing it. So that those were the days when we had to actually work hard. Those were the days when we had to, the seminar presentation was happening every week, and how we were preparing, we were the last of the lot who were presenting seminars on OHPs, the last of the lot, because just after that, 2-3 years down the line, our juniors started with the PPT presentations. But we were the, and I still remember having those plastic sheets, having those colored pens, having those lined papers on which we used to keep our OHP plastic transparent sheets and write it and have that liquid eraser. कुछ गलत हो जाए तो कैसे होगा? Those were the days when we were actually very scared of our head of the departments, actually very scared of our teachers, that yes, whatever task is being given to us should be done with perfection. So, not scrolling, just turning the pages of a number of textbooks that we had, just seeing the diagrams, going to the library were the days. So, we had to really work hard. Now, see, the fruit of success is only if you are working hard. The only difference is the modality of hard work has changed. We would not say that because everything is available at the press of a button, the students do not, or the learners do not need to work hard. They will have to work hard. Only thing is, that the mode of hard work has changed. The fruit of success is always to the learners, cannot get without perseverance, without persistence, and without sincerity and hard work. That is the core element, the human value which the AI cannot replace. So, but along with that, if we use the digital tools available these days, then I'm sure sky is the limit. So here we go. Now, this is one of the tools of digitalization, the laptop that you see on your screens. How the medical education and our education system, the journey evolved. It started from epics like Shruti, Smriti, Samhita. These are our epical, all of you know, scripts. Coming to the Mahakavyas, then came the relatively modern system of teaching, that is the chalk and talk. I'm not very sure how many of you in the audience, because I'm definitely from the chalk and talk period when you're looking very young to me. So I don't know. Very few senior people, sir, I'm sure will agree to me. Madam, you might agree to me that we are from the chalk and talk era, the times when the teachers used to come to us. And those were the days when the teachers were actually called teachers and we were called students. So the teachers used to come to us in the class. And I still remember, I will not name the teacher, but we had in the first professional, when we were in the first year, we had a teacher in physiology department who had his diary. And as first year students, our biggest guides and mentors were our seniors of second year. I'm sure all of you will agree. Those were the days of ragging as well, and bad ragging, because of which it got banned. एक होता है ना, कहते हैं पाप का घड़ा जब भर जाता है तो फट जाता है. So in those days when we were undergraduate, तो वो पाप का घड़ा भर के almost भर चुका था. Those were the days when first year में जब students आते थे तो एक का कम से कम बैच में फ्रैक्चर हो जाता था, क्योंकि वो डर के हमारे सेकंड फ्लोर से कूद गया हॉस्टल के. एक का कम से कम टिम्पैनिक मेम्ब्रेन फट जाती थी क्योंकि उसको इतनी जोर से थप्पड़ पड़ा. सो दोज वर द डेज व्हेन सीनियर्स, इमीडिएट सीनियर्स वर आर एक्चुअल गाइड्स. तो उन्होंने बताया, एक सर आएंगे और उनकी एक डायरी होगी और उस डायरी के पेजेस पीले होंगे और वो डायरी पलटेंगे और वो पलट के पढ़ाएंगे. सर, आई होप आई एम नॉट like it's a long session I was given. Okay, so I can just I'll rush through my session. Oh, sorry, sir. So I'll just rush through I was supposed to take 1 hour, so I thought, okay, so I'll just take 10 minutes. 9 to 10 we started late. Okay, so I'll just rush myself. So we were told that वो येलो पेजेस पलटेंगे और उसी से पढ़ाएंगे. So that is what was happening, कि chalk and talk वो era था. उसके बाद आए OHPs when we were doing our post graduation. Then I PPTs, which are very prevalently being followed these days also. But the difference is that these days the PPTs, we can get wonderful data from our artificial intelligence, the digital tools that we talk of, from the internet, from the researchers. So that is what. Now what next? Teaching evolved and it continues. We have already talked about the traditional medical education. What were the limitations? Its scalability, its personalization. You cannot, like, if a student is weak, you cannot personalize. It is overall generally being given for the entire class, for the best student as well as for the poorest one. So that was about the traditional method as well as its scalability. Now, the drivers of digitalization, what are they? Number one, there are certain tech advancements, definitely like the artificial intelligence, the virtual reality, we all know about VR, and the mobile apps. Second very important thing is the remote learning, which is possible through teleophthalmology. Not about teleophthalmology, I'm into ophthalmics, so I talk through telemedicine, to a broader subject, as well as through the AI tools. It demands for lifelong learning, as we have said, because of the changes happening so rapidly. So we need to keep ourselves also aligned to it, as well as it allows for global collaboration. We have so many online portals through which we have Zoom online meets. So that allows for globalization. So we have a lot of platforms. To name a few, the e-learning platforms include the Coursera, the MedEd portal. Virtual stimulations include the virtual reality, the AR anatomy reality, the surgical practices in which we have those game like apps. We just need to strap it around our eyes, and we have a virtual world of whatever surgical skill that we need to have. We have our hands, we have a simulation in which we are operating, and we are learning not only the techniques of suturing but the techniques of incision. So that is what it is helping. The mobile apps give us a very quick reference. What are the benefits? They are available anytime, they are available anywhere, the access is there. It's a personalized learning path, that is, to each their own. We can change the way we need to learn, we can change the way we need to teach. It is interactive because it allows us to interact with the audience. We don't need to just go turn ourselves right on the blackboard. We have everything available on a screen being displayed for the student. So it gives us time to interact with the student. It is cost effective and helps in getting us trained. But every rose has its thorns, as they say. तो सारे तो फायदे होंगे नहीं, कुछ तो उसके challenges भी होंगे. So what are the challenges? There is a digital device. There are areas which do not have internet access still, especially in countries. Ours is still a developing country, aiming to become a developed country by 2047. But still in 25, we are developing country. Rural areas do not have a lot of areas with access to these internets and fast areas. Faculty training is very important, which needs to be done. Not only in the terms, it's a graph in which our faculty needs to get trained, but the most important thing is the desire to be trained. That is what that needs to be inside of us to get ourselves properly. Reduced hands-on exposure and data privacy is also a major concern. So case studies, what are the important things in which we can use it? So case specific, we can have virtual reality for teaching and surgical training. Telemedicine can be practiced for students who are in remote areas, and AI diagnostics tools to improvise. I'm sure most of you are using so many AI tools in which we just need to put what we need to do. Just plan my lecture as per this topic. It will give an entire short briefing of what we need. Plan an assessment. It can give us an entire assessment. Plan an easy assessment for MBBS students. Plan a tough assessment for postgraduate students. And it can give us an entire range of questions which help us in planning for our students. Similarly, we can plan our lectures for different stage of learners. This is what needs to be done. All of us know about artificial intelligence. It helps not only in decision making, but also it gives us a power of reasoning. Why this happened and
Dr.
how
Ruby,
this happened. Yes, yes, sir. So I would like to conclude my talk by saying that artificial intelligence is the call of the day, but we cannot be 100% dependent on it. We have to take a brief outline. For the students, I say do not blindly take into artificial intelligence and digital tools. Use it as a helping tool and make your own decisions, make your own reasoning, and use your own convoluted neural networks along with AI to improvise upon the medical education, the learning, the teaching. Thank you so much.
Thank you, Dr. Ruby Malhotra, for this very important topic
I'm sorry,
on
sir.
which is the need of the hour. We will take the question in the end because there are two more speakers. Now I hand over to my co-chairperson, Dr. Tanvir.
So I invite. Now, I would like to invite our next speaker, Dr. Shaili Vyas Ma'am, who is professor at HIMS SRHU Dehradun, Joint Secretary IAPSM UP UK. She is the Vice President of AFPI Uttarakhand, recipient of IAPSM Awards 2021 and 2022. She has organized three national workshops and one national conference. She contributed chapters to IAPSM book, reviewer for indexed journals. She has 70 research publications, chaired sessions in national and international conferences. Ma'am, you can begin with your speech.
May I have my presentation, please? Good morning, everyone. Um I'm privileged that I have been given this topic because this topic is very close to my heart. Uh, as I am doing my ACME right now, and I'm doing a project on the same, that is digitalization in medical education. So I'm going to share you all my experiences in digitalization, what I have been using throughout these years, and my experiences started from COVID-19, in which we took lectures also. Everybody, I mean, each one of us has took lectures also on Google platform, on I mean, on various platforms. So I'm going to share you my own experiences through this presentation. So as Ruby ma'am has already laid the foundation why digitalization is important in medical education. Digitalization, I would say, is no longer optional. It is rather essential, because the students need have been changing, whether it's a postgraduate, whether it's an undergraduate, whether it's a PhD student. They desire flexibility, personalization, personal I mean, teaching methods, and technology enabled learning. So it's an era of CBME, which demands continuous, skill oriented, and measurable learning support. So we have to offer the digital platform to our students, which offer flexibility, self-paced learning, and high quality content. So the key drivers of digital transformation, one of the dream of our PM Modi, of our Prime Minister Modi, is National Digital Health Mission. As we all know, that even our CBME, they have like frame certain rules and regulations for integration of digital health literacy into the medical curriculum. Telemedicine, yes, telemedicine and e-health growth, like with e-Sanjeevani, and in Himalayan we are running it through him Sanjeevani. Dr. Neha will elaborate further on it. But these are the two things. Like in Uttarakhand, I'm staying in a I'm from a terrain which is very difficult. Like in Uttarakhand, we are using this for the far flung patients, and it has we are also training our interns and the medical students how to use these e-Sanjeevani and telemedicine platform for patient care. Then the pandemic driven adoption, as I've already told you, my first experience starts from the pandemic era of digitalization, of using Google platforms and Google classrooms and meetings, training our medical students through Google platform. Then the AI, AR, VR, and the simulation based learning, which we have already started in our institute as well. And Dr. Neha will further elaborate on simulation based learning and AR, VR platform also. So this is we are basically using in our system, in our medical college, mainly we are using the LMS, that is Moodle. I have personally used Moodle and the Google Classroom, where we have in the year 2021 we were awarded a project by I mean, I was the one of the co-investigator in the project with Dr. Ashishman and Dr. Rivu Basu on the project Indrani. And what we have done in that was using the Moodle platform for the postgraduate. First, we did a need analysis of the postgraduates on NCD, on identifying the NCD risk factors. We did a need analysis, need assessment, and then we developed a checklist. We developed a module based on the experts. We took a qualitative research interview, like we took a interview, in-depth interview based on qualitative research of the experts, and we developed a module based on the need assessment of our postgraduates. And we have certain online lectures also, here is a video of that lecture also. We developed a module, and then we trained them through online teaching platform, which is module, and we then assess them, and based on their percentage we have given them this certificate. And one of the participant, he was being awarded the best oral research presentation based on that module. So this is one of my experience with a Moodle platform. Then there are versal dissection table, which Ruby ma'am has also talked about. And there are Swayam and Neptal. We already know that we have all been trained in BCBR, and it is being provided through Swayam and Neptal platform only. So gamification and interactive quizzes. I think most of us, I think most of you are aware that we are doing online quizzes also, and it is through these modalities. Like we are doing quiz through 2 or 3 apps, like the Quiz Allies app. This was one of our quiz which we did during the COVID time, and uh, sir was one of the sir was the president at that time, uh, Chopra sir. So we did this quiz, and till date we have done almost 26 quizzes online. Yesterday it was a 26 quiz, and today we are doing the finale also. So this is one of the platform like interactive teaching learning method. We are doing it through various apps. This was one of the quiz which we did for tuberculosis. This was the TB quiz, and this is the this is one of the apps where we use. Here's a timer, the 14 seconds timer. It's a timer based quiz, this thing. And based on it we get the response, like 15 had marked malaria. I mean, this is the, I mean, these interactive tools, it is as compared to the conventional method, they are more I mean structured, and they are very interactive, and you get the responses, you get the answer there and then only, the students get the answer there and then only. And based on these quizzes, I have, like, the scoring is also there. Team 3, like the scoring is there of team 3 or team 6, and we get the scoring. And on this, keeping this in background, my I have I mean my Acme project on is in this background only, that the satisfaction and the performance of students on based on these quizzes. So this is one of my Acme project also. This is how we do the quizzes. This is my project on advanced course in medical education, the use of online quizzes. Like at the end of the lecture I used to take online quiz, and then I used to compare it with the conventional teaching method, like the paper and pen method of quiz. Then this is one national platform, national conference which we did in the year 2022. It was of IIPSM Nagpur, where we assessed the online paper presentation of our PG students, and the best paper presentation was being awarded, and it was again online. So I'm just this was SNC, that is Sub-National Certification of TB, where we did a qualitative or the in-depth interview of the pharmacist. And the WHO coordinator is with us. Our senior professor is also with us. So we did, I mean, in this also we use one of the online method. Then this was a course which we developed for IAPSM in collaboration with Indian Institute of Public Health, where I was a coordinator for the this was for postgraduates and for the young faculty for the OSCE and the OSPE method. I was the coordinator for OSPE and OSCE method, and we developed certain modules, and certificates were being given based on the hours each PG, each postgraduate, or each young faculty they dedicated for that module. We used to calculate the credit hours, and we used to award them certificates based on that. So this is one thing which we did for in collaboration. IAPSM did in collaboration with Indian Institute of Public Health, and this was also based on LMS method. This we use the LMS method. Then the PG competition. We used to do several PG competition of IAPSM. We did the tobacco competition, the online tobacco competition, where we heard the name of the competition was Idea Fusion. We invited PGs across India, and 10 PGs were selected, and we asked them to present their idea which can make a difference in the field of tobacco. So we got many presentations, and sir was also one of the chairperson at that time also. So the top winners also was declared. So these are certain things which we are using in medical education also, in postgraduate program also, in undergraduate program also. We are doing these through IAPSM. this is one thing where we develop modules. This was one of the collaboration of IAPSM with IPHA and with IAP, with Foxy. 5 associations were there, and we were asked to develop module for. I mean, I was one of the lead for developing a module for nursing and medical students on comprehensive sexuality education. So it is in pipeline, and it will be soon be like I mean soon be launched. So this is something which we developed online, and the training of the same will be also be done online as well as offline. Career guidance, we have masters in epidemiology students, where faculties from across India or faculties from abroad, like sir is very senior, Bansal sir, Dheeraj Bansal sir. So he have been training our medical students in masters in public health through online courses, and he used to guide those students, he used to sort out their queries. So this is one thing which we are doing in our institute, and we used to provide them with a certificate also, and they used to take online lectures in our for our students. This we did in Uttarakhand, that is online workshop for development. This we did of faculty as well as district tuberculosis officer. We had their training, and we assessed their needs, and based on their needs, we collaborated with them, with the medical colleges, faculty of medical colleges, and we asked them to develop a project proposal based on the need of district tuberculosis officer. The faculty, they developed a project within 1 week of based on the needs of district tuberculosis officer. This we did in Uttarakhand for the first time. This was an online workshop for development of project proposal, and we were the facilitators for the same. So simulation and skill lab, this ma'am has already covered, Ruby ma'am. This also ma'am has already covered. So digital evaluation method is by OSPI and OSCE. CBME logbooks, e-logbooks and digital portfolios. This we have recently, I think 1 month back, we are doing this with the PGs, the digital portfolios of the postgraduates. This I have already told. This, like my PG, I've taken a certain lecture of the postgraduates, and this, suppose they have filled my name that Dr. Shelley has taken this lecture, and I have to give them marks based on the assessment what they have done. So this is a reminder on my email that pending approval. This was like, this needs approval of the faculty to assess the postgraduates. This was there in my mail. So this is a screenshot of the same. They have the PGs are supposed to develop a e-logbook, and there's a portal of the same for the same, and faculty has to assess them. This is the faculty dashboard. I have to assess my postgraduates based on my teaching and based on the assessment. I mean, daily they have to take codes. I mean, the patient, and I have to assess them based on the patient they have taken, the prescription they have written, then the thesis which is going on under me. So I have to assess them based on that, and the reminder keeps on coming to me on my email until and unless I assess them. So the moment I assess my PGs, all the PGs, the reminder goes off. So this is one thing which Himalayan has developed, and which we, I mean, it is, I think 1 month or 2 months back, this initiative has been taken. Advantages also, Ruby ma'am has already covered, so I don't want to. Challenges also, we have already, one thing is screen fatigue is one of the thing, and data privacy and ethics, which we have not covered. Role of the digital, with digitalization, the teacher's role is evolving, and we are from the stage on the stage to the guide on the side. We have converted to that, and it facilitates from delivering lecture to facilitating. We are now facilitators rather than teachers. We are facilitators of the medical students. So way forward is, it is a well-defined institutional digital strategy. There should be regular faculty development programs. Innovative pedagogy should be there. Simulation, flipped classroom, and blended learning should be incorporated, and a commitment to evidence-based teaching practices. So digitalization is not replacing teachers, it is empowering all of us, and we do agree to that. The future of medical education is blended, interactive, and innovation driven, and our role as educators is to blend human touch with technological excellence to develop competent, compassionate future doctors. Thank you, everyone.
Thank you, Dr. Shally, for nice presentation. And now, next speaker.
Thank you so much, ma'am. Now I would like to invite our next speaker for this session, Dr. Neha Sharma, ma'am. She's Associate Professor, Department of Community Medicine, in HIMS, Dehradun. She's MD in Community Medicine from KGMU, Lucknow. She's the winner of National President Appreciation Award. She's resource person for MHM, breast cancer workshops and training. She's the state assessor for EVM, reviewer for journals. She has 35 publications, book chapters, and multiple awards in academics and sports. Ma'am, please begin with your session.
Thank you. Good morning, everyone, respected chairpersons, senior faculty members, juniors, colleagues. First of all, I would like to thank Dr. Bilal, sir, the organizing chairperson of this conference, for giving me this opportunity to speak on this topic, digitalization in medical education. And of course, it's my privilege that I'm sharing the platform with my chief guide from my PG days, Dr. Jamal Masood sir. And if Ruby ma'am doesn't remember, but she has also been my teacher during MBBS days. You taught me opta in when I was in Era Medical College. So thank you, ma'am. So I'm really honored to be here. Yeah. So, lot has been told about digitalization in medical education by Ruby ma'am and Shelly ma'am. They both have actually, decreased my burden, my job in this. So I'll just go through what work we are doing in Himalayan Institute of Medical Sciences with respect to digitalization. This is the burning topic and the need of an hour, the backbone of competency based learning. So it is, digitalization is not about just tool based, it's about the ecosystem that we have developed, because this ecosystem basically helps us to integrate the teaching, the assessment, the clinical skills that students develop, and also about the patient care. So this approach allows us to even track competencies and personalized learning and improve the outcomes at every stage. So, our college, Himalayan Institute of Medical Sciences, Swami Rama Himalayan University, has taken a major digital leap in the establishment of the first Uttarakhand uh, artificial intelligence and virtual reality based medical stimulation center, which was recently inaugurated by Dr. Vinod Paul, the member Niti Ayog, and in the month of October. And this basically center will help to practice complex clinical procedures which can be done by the students, enhance decision making, especially under pressure, giving them the scenario of how they have to manage the patients, reinforce theoretical knowledge through real world simulations, and also capacity building and professional development of not only the students but also the teachers as well. And it is not just for the MBBS students but for the nursing and the paramedical student as well. And this all has been done because of our visionary leader, the pro vice chancellor, Dr. Ashok Kumar Deorari, who has this vision of starting this virtual reality center. So our college already is the regional center for medical education unit, and we are moving towards the digital medical education. We have also the skill lab at HIMS, which helps to focus on digital strengthening, because we have high fidelity simulators which are digitally equipped, so that students can have hands on that mannequins and simulations. They have the real scenario, how they have to deal with the patients, and whether they are doing bedside teaching or in handling any emergencies, be it delivering the this child, or even intubation, for simple suturing, BLS classes, venipuncture, all are being told to them in the skill labs, and these are all digitally equipped. So our skill lab helps in introduction to him simulation and equipment. These are the pictures of our wonderful gynecologists and pediatricians and the nursing staff, who are almost there in the lab to teach the students. They come in short groups. So we have involved a small group teaching and self-directed learning classes also through our skill lab. So beyond simulation, there's the power of debriefing in medical education. We emphasize on this very much whenever we are telling the students about how they have to handle the mannequins and the simulators. There's a structured debriefing that is being done to them, so that there is no harm to the simulators as well. Application of adult learning principles in simulated environment is being given to them, so that professionally how they can be sound enough when after becoming the doctor, they are in the feel in directly talking to the patients. So the adult learning approach is also given through them through the skill labs, and we are also integrating certain apps and innovative techniques to improve the fidelities. Then Dr. Shelley ma'am has already emphasized on gamification in medical education. We have been using certain games for teaching students, not just for the quizzes, but in our, again, lecture theaters, in our small group teaching, and in our self-directed learning classes as well. We have used Quizalize for a long time. It's been more than 5 years that we are using this app. It helps to give points, scoring system, leaderboards, even the levels and the badges to the students, so that they have this constant improvement, this enthusiasm that yes, we have to score more good. And when the musical background is also there in this apps like Kahoot, so when they are actually attempting in the class, and you have a background when you the score is on the screen, so the adrenaline rush is always there in the students, that yes, I have to answer quickly so that I'm on the leaderboard. So there's a quick reaction that we get from students. And on the feedback also, we have got that they want that more such kind of apps should be utilized in our teaching learning method, apart from just the PowerPoint presentation that we usually do. Then we have also used gamifications in storytelling sessions as well, how we are describing any case to the student, so that it's not boring, but they are actually engaging, and they stick to it, that yes, we have to listen to the whole lecture, and it's not just the boring part that they have to pay attention for just like 10 or probably 15 minutes. We also give rewards to these students, because based on their levels and their scores that they get, so that it's like an incentive to them to do more better. So gamification helps in promoting active and self-directed learning, that ma'am has also said, Ruby ma'am, that we have to have that switch from the traditional learning method to the active and the experiential learning methods. It improves clinical reasoning under pressure, enhances participation even in large groups, and supports competency based progression. Apart from Quizalize, Kahoot, and Moodle, we have also used Quizzes app in this for having MCQs. uh, we have also given lectures and developed faculty development programs in teaching these apps. Recently, in the month of October, the FDP was done on Kahoot, from lectures to leaderboard, gamified teaching with Kahoot. And not just the medical, but our university is also having the faculty from the engineering institute, from a management institute, from the yoga sciences, so that every person, every teacher has their own experience when they are talking about these gamification tools. So we have also developed online OSCE stations for better learning of the patients regarding the clinical case scenario, and they are well prepared for the checklist during their exams. For the BLS, suturing, and the injection procedures, we have digital batches whenever they are visiting the skill labs. The leaderboards for the skill performance, we also give the first, second, third position to the students, so that whenever they are performing, so how well they are performing. And peer competition through Quizalize heat maps, like I said. Now, this Canva for medical education has been a boon. I'm sure everyone sitting over here must have used Canva. In fact, the ongoing this collaboration of IAPSM with ICMR on World Health Mission, all the documents which are being prepared by the Health Education Committee has utilized Canva application only, be it preparing the flyers, the brochures, the announcement for the e-posters, or for the reels, even for preparing reports as well. This application is very handful for framing all the PPTs. Even my PPT I have developed in Canva application only. So this is something very innovative, and we should have more classes for students as well, because most of the times we have just for the teachers, because we have to teach in the class. But for our students also, we should have certain kind of SDL and SGDs, in which they should know how they can utilize Canva. And students are very active. So just we have to give them a good guidance and a priming, and they are good to go with this. So this simplifies the complex concepts, supports competency based learning, and quick IC material creation, like I said, that we have been using for our One Health mission as well. About Swayam Neptal, Shelly ma'am has already told that we have this massive open online course which is being developed by Government of India, Swayam, and the national coordinators from the IITs, the NPTEL, who are managing all these. They are different courses in which the students can use for their learning, especially to enhance their interdisciplinary knowledge. So for this, what our college has done, in any discipline, if the student is registering in the Swayam NPTEL, they have to register through our college ID only. And whenever they are giving the utilizing these courses, and they have to give the exam, so at the end, when they are getting the completion certificate, the refund they get from the college. So we have given Swayam NPTEL course name that the Swayam has given, and we have integrated with our SRHU course name, course code, and course credit, and these are also being added in their mark sheet. So next time when they are applying for their jobs, so it is there in their mark sheets, and it can be added in the CV as well. So it will be good for them if any of your student is doing this course, and if this can be incorporated in their mark sheet, that will be very beneficial for them. Telemedicine services are being provided in our college. So we are again utilizing this platform. It's a Bangalore based company which is TeleVital, which is Vitalware software that we are being using for last more than 4 years. And it's a very remote area. Basically, our Swami Rama hails from a very small village. It's in a Pori Garhwal, that's Toli village. And our honorable president, sir, of our university, he wants to serve that village. So we started with the telemedicine services. The medicines are being provided free of cost to those people. And in the last 4 years, we have almost catered more than 20,000 people over there using these telemedicine services. And we also utilize our interns and the MBBS students right from the second year, so that they know how the telemedicine consultations are being done. They know how to handle the virtual consultations. They know how the digital health records are being prepared, and about the ethical and the legal things that they should keep in mind when they are dealing with some patient virtually. So they have hands-on exposure when they're directly talking to the patients to the virtual mode. So I would just conclude by saying that digital transformation is no longer optional. That Shelly ma'am also said that's the need of the hour. We have to move with the transformation which is going on. And if we are not using any digital tool, then we are going to lag behind. So it should be part of our life. And it also helps in faculty empowerment, student engagement, and institutional support. And integrating all these tools via AI or VR based simulation centers or gamifications, it will eventually enhance the student engagement. And we are not just focusing on making the students just clinically competent, but digitally responsible as well. So thank you. Thank you for your attention. If you have any questions, I would be happy to answer. Thank you. Thank you.
During a session which
Thank you, sir. Thank you so much. Thank you, sir.
and you may ask questions from any of the three presenters, but only one or two questions, please, because we are already running short of time. Thank you.
Sir, any question?
It's not a question, it's a compliment to all the three speakers who are using the digital technologies. And I think the first speaker emphasized it absolutely correctly that we started from chalk and board and then from transparencies, then to PPT, and now we are using apps. My only point is this, that whenever we use a new technology, it is important to do the impact assessment also, because we think that we are doing a great job, but what ultimately, whether it is benefiting the students, and are we able to do an assessment prior to what we were doing and with the technology what we are doing, because that is again much more important to understand. Because yes, technology is for everybody, but on a learning mode where students have to learn and remember, because that is very, very important. For teachers, it could be very good because it's a very good resource, and there are multiple apps, right? If you use Gamma, you have every presentation with you within few minutes, and you can do the presentation from the Gamma itself. So that's not the issue. But ultimately, it is important, because if the students, they start using this, then how much will they be able to remember, because they have to ultimately pass in the exam, and that is all based on the remembrance. So we are in a dichotomy right now, whether to give absolutely emphasis on the digital mode and media, and whether to still use the conventional methods also, because these are important, because our assessment methods are still based on the previous system. Until unless we change our assessment methods, like only then I think we can say. And the third thing, which is again very, very important, you may try simulation or you may try anything. Ultimately, when you come directly in contact with patient, how you are going to behave and how you are going to do that. So that's a thin line which we'll have to keep in mind. Of course, everyone is doing a great job where the resources are there. And the second point is, our government colleges are competent, or there are facilities available there to incorporate all these things, because India is a humongous country, and more than 700 medical colleges, more than 350 medical colleges in the government sector, and few colleges even don't have the facility of internet. So internet divide is also there. So all those things are very, very important. But ultimately, until unless you do the assessment prior and after, only then we can say that the results are good or bad. Thank you so much. These are my suggestions.
Thank you, sir. I absolutely agree with what you have said. And I always remember one line: anything in excess is always bad. So it's not something that we are just completely, we have to be dependent on digital, because obviously it's going to harm our eyes also. Screen time badhega, so it will affect. But how we have to do a balance between whether we are reading from books and how much we are earning from these apps. That's more important.
Thank you, sir. Thank you, Dr. Ruby, Dr. Shali, and Dr. Neha
Thank
for
you,
such
ma'am.
an elaborative, interesting, and informative talk. And congratulations to both of you, and you also. You are doing so much in this. Yes, medical education digitalization is a need of ours, as sir also said, and it should be integrated with the teaching and learning to make more effective. So it was a nice presentation. Thank you, speakers, and thank you, audience.
Thank you, ma'am.
Thank you, speakers. Thank you, everyone. Now, I would like to request Dr. Tanveer Bano ma'am to please felicitate our first speaker, Dr. Ruby Malhotra ma'am. Now, I would like to request Dr. Jamal Masood sir to please felicitate our next speaker, Dr. Shaili Vyas ma'am. Now, I would again request Dr. Tanveer Bano ma'am to please felicitate our next speaker, Dr. Neha Sharma ma'am. Now, I would like to request Dr. Ruby Malhotra ma'am to please felicitate our esteemed chairperson, Dr. Tanveer Bano ma'am. Okay. Now, I would like to request Dr. Syed Fiza ma'am to please felicitate our esteemed chairperson, Dr. Jamal Masood sir. Thank you, ma'am. Thank you, sir. With this, we end our first session for the day. So, beginning with the next session for today, which is maternal, newborn, and child health. It is both a public health priority and a moral imperative. Sustained investments, evidence based interventions, and community centric strategies can ensure that every mother, newborn, and child not only survives but thrives. Integrated approaches such as One Health framework, climate resilient health systems, and digital innovations are shaping the future of MNCH in India and globally. So, to begin this session, first I would like to invite our chairperson for this session, Professor Dr. Medhavi Agarwal ma'am, who is a professor, community medicine, RMCH Bareilly. She's a gold medalist in MBBS MD community medicine. She has 12 plus years teaching and field experience, 30 plus publications, reviewer for reputed journals, contributor to ICMR and WHO projects, active in NV, BDCP, RCH, and COVID 19, and she has been awarded by PATH, EC member and state coordinator, WHT quiz. Ma'am, please take your seat on the dais. Our next chairperson for this session is Dr. Malika Ma'am, Associate Professor, Department of Community Medicine, Integral Institute of Medical Sciences and Research. Ma'am, please come over the dais and take your seat. So, for this session, our first speaker is Dr. Harivansh Chopra, sir. He is the President, National IAPSM 2022 and 23, former professor and HOD Community Medicine at LLRM Medical College. He has 39 years of experience of academic and public health. He has 100 plus publications with a strong citation impact. He has mentored 55 plus specialists and served 2.5 lakh plus patients. He has led major CME workshops on malnutrition, TB, HIV, AIDS, and BFHI. He's the recipient of notable national awards and widely recognized for online academic contributions. So please come over the dais and begin with your speech.
Okay. Yeah. Can all of you come a bit forward? It'll take 1 or 2 minutes, but it'll be good for me to make eye contact with all of you. If you can come forward. And while you are doing so, can I have a mic, hand mic? Well, at the very outset, I would like to pay my gratitude to Dr. Bilal and the organizing team of this 28th State IIPSM conference for inviting me to share my thoughts on child health. I'm also grateful to the team of IIPSM UPUK chapter, Dr. Manish and Dr. Bhavna, who constantly cajoled me to come and join all of you in this particular conference. So thank you very much for inviting me. What I'm going to do is child health, as all of you know, we have to go a long, long way forward. And when we talk of child health, then it starts from neonatal health. And that reminds me of my first presentation, which I did at the national conference in 2003, which was sponsored by a WHO on essential newborn care. And the concluding slide of that presentation at that particular point of time was that if we have to reduce infant mortality, we have to reduce neonatal mortality. So we said it, and I think that is the job of the academia to talk about what is happening, whether it is happening in right manner, and what is the vision forward. Because until and unless you are able to do that, then what you are doing is you are simply following the programs which the government has put in, whether strategically, technically, whether they are correct or not, or whether they are yielding the result or not. The result of that recommendation in 2003, Indian government came up with the Indian Newborn Action Plan in 2013. That is how the public health works. That is point number one, which all of you as a young professional must understand that it takes a lot of time. The second thing which came to my mind as far as the child health is concerned, we were having a symposium in the Kolkata where it was a IPHA conference, and the symposium topic was gaps in medical education in maternal child health. There I did a presentation on gaps in maternal and child health, and I recommended that we need to have a comprehensive program. And what the program at that particular point of time was running was IIMSR, but none of the government college or the private college was implementing it. Thanks to Professor Sanjay Roy, who followed it up with the government of India, and finally we could have that IIMSR training with the support of UNICEF and WHO in all the colleges. And going back to that IIMSR strategy, one has to understand that whatsoever under 5 child mortality is concerned, 50% of that mortality is because of the underlying undernutrition. So I thought it will be pertinent, it will be good if I can give maybe 10 or 15 minutes on prevention of undernutrition in under 5 children. And today I'll be talking about it not in greater detail. Maybe I'll be giving you a synopsis. What is the data-driven evidence? Whether we are able to follow that evidence correctly, or do we need to shift the strategies? Besides that, you'll have to understand there are a lot of international agencies, and Dr. Bilal himself has worked in WHO. And these people, they keep on, I'm not criticizing them, because they have to keep the focus on child health, on maternal health. So what they try to do is they keep on adding the old wine into new bottles and keep on giving new names. As we'll be going through the topic, I'll be talking more about it, right? So what has been done over the years, that from under 5, the focus shifted to 1,000-day approach. And those of you who are interested, want to know more, I say no, India does not deserve 1,000-day approach. We need only 635 days approach. And those of you who are interested can read the editorial of the West Bengal IIPSM journal, which is there. Then secondly, now we are talking about early childhood development. Again, that is again important. But whether do we need more stimulation, or do we need to attack the problems first, which are responsible for the deaths of the children in our country? And India is a huge country. One has to remember, we produce more than 2 crore children in a year, right? So with this, I'll be moving forward now. And the only program which addresses malnutrition in our country is ICDS. And ICDS was launched on 2nd October 1975. Almost 50 years. When I was a student, I was taught the undernutrition is more than 50%. And I'll be concentrating only on undernutrition because I firmly believe that it is a absolutely preventable phenomena, and it can be prevented with the help of primary prevention interventions, right? So I tried to search the impact studies. ICDS, there are hundreds of studies, but very few studies are there on the impact. That is what I was saying in my comments in the last session. You'll have to see the impact. Whether it is making any impact or not, you are seeing the functioning, you are seeing the coverage, but you are not seeing the impact. So I could come out with 2 studies, and unfortunately, one of the study is again done from our own college, and both of these 2 studies stated that supplementary nutrition has no impact as far as malnutrition is concerned. Right? So let's start our journey, and now I'll be doing the data presentation. Now, again, this is a simple chart, and it is showing you the data from NFHS 1 to NFHS 5. And if we concentrate only on underweight children, because that is the beginning of malnutrition, rather the growth faltering is the beginning of the malnutrition. So if you look at it from, you can say 53%, we have come down to 32.1, and this was done in 91-92, and this was done in 2021. So you can see 30 years, and reduction is 20 percentage point. Is it correct? As a public health person, as a program manager, are you satisfied with this kind of a performance of a program which is said to be the world largest program? So what is wrong with that? So we'll be talking a bit later. Now, this is a slide which is taken from NFHS 2 finding, and it's a very, very important slide. Majority of time we think undernutrition is happening, it is happening because of lack of food security. It is lack of food. Then it means it should not happen, it should not at all happen in the middle income or in higher income, right? If that is the premise, if that is the hypothesis. So let us see. So this is the data of NFHS 2, and it is in relation to the living index. Now you see in the highest strata, 26.8% children in the highest strata, they are underweight. Now we are not talking about the people who are living in poverty. We are talking of people who are having the highest socioeconomic status, right? So, and even if you look at the medium, it is 28%. So approximately a quarter of children belonging to the highest and the middle strata, they are still suffering from malnutrition. That means there is no dearth of food as we think, hypothesize that there is no dearth of food as far as these children are concerned. Then we go to the next slide again, and that is again a very, very important slide, because you have to do a segregation. What we say is you have to do a segregation, and that is in relation to the age. Now, if you concentrate here, now, what is the status of underweight less than 6 months, 6 to 11 months, 12 to 23 months? So what you find here is that the maximum underweight children are in the age group of 12 to 23 months. This is data driven. This is not my and this is all government data. This is all data of NFHS. And there is no bigger data than the NFHS in our country, right? So if that is the phenomena, that majority of the children between 1 to 2 years of age are already underweight, it simply means that the seeds of the malnutrition are sown in the first year of life, right? And what we have been doing, we are concentrating on under 5. Imagine the workload on a poor Anganwadi worker, where in each Anganwadi she has to take care of 150 children. And suppose if we reduce it down to 0 to 1 only, see the amount of work which will be reduced, right? And to support this finding, I'm showing you a growth chart by WHO, right? It's all data driven, it's nothing my. So if you look at this growth chart, again, what does it shows you? It shows you that right from the time of birth up to the age of 1 year, there is the weight gain is maximum, and it is touching somewhere around 10 kilogram from say 3 kg to 10 kilogram. That is the median here, right? So in the first year of life, there is a weight gain of approximately 7 to 8 kilogram. And of course, those who are further interested, there are 4 of my lectures on prevention of malnutrition on my YouTube channel. You can go through them. There is a detailed growth chart. There is a detailed growth potential phenomena which is there. I cannot, because of paucity of time, I cannot do that. And after 1 year, 1 to 2 years, 2 kg, 2 to 3 years, 2 kg, 3 to 4 years, 2 kg, 4 to 5 years, 2 kg. Now you can simply ask yourself, if the growth velocity is maximum in the first year of life, where we should concentrate? Shall we concentrate in the first year of life? And that reminds me of another story which happened. This is a real story. I want to share it now because I want to divert your mind from the data to real stories. This is a story of early 90s. My wife is a gynecologist. She was working in a women district hospital, and an underweight child was delivered in that hospital. And at that particular point of time, there was no pediatrician in that hospital. And because I was the husband of one of the gynecologists who was working, I used to see all those kind of children. The name of the child was Sonu. The birth weight of the child was 1.5 kg. There was no government facility where this child could be hospitalized as per the standards of Indian Academy of Pediatrics. Below 1.8 kg, you'll have to admit the child. There was no money. And I always say, you see, there is an opportunity in adversity. So mother brought the child to me. I examined the child. The child was able to suckle, was able to swallow. I said, you take the child home. And I said, we will take care of the child, but then you have to be very, very cautious. You have to bring the child maybe on 10th day, then another after 10 days, and then every month to me, and we will see the progress. You'll have to keep the child in a hygienic condition, and you have to give your breastfeeding to the child. Nothing else is to be given. So that becomes the Sonu's big win. And I think Dr. Seema is sitting here. We did a presentation in the Asian Congress of Nutrition maybe in early 2000, Sonu's big win against malnutrition. And that gave us the confidence that it's not normal child. You see, I have followed up thousands of normal child, and I always say the target is 10 kg. If by 1 year of age, you can achieve the weight of 10 kg, whole problem is solved. And I'll be talking that big win strategy today, that big win approach today, which we developed over a period of time working in the field. And the take home message here for all the people of community medicine, for all the people who are working in the departments, or maybe for the pediatrics people also, go and work in the community. Only then you will develop the insight. Only then you will be able to come out with the innovative approaches, right? So we move forward and we say, if we are able to prevent malnutrition, we are promoting the child survival. It's as simple as that. And the target take-home message is that every child at 1 year of age must be weighing 10 kg. How that will be possible, we will be talking about it. But we do say malnutrition is a big problem. As a student, I was taught 50%, and the recent data is saying 32%. I am talking about underweight. I'm not covering wasting, stunting, because these are the phenomena. Again, they are controversial. We'll end up in the different controversies. So if there is a big problem needs a big solution. So it has to be a big win against malnutrition. And if one wants to win the battle, the effort has to be intensive and focused. Right? Intensive and focused. A big win strategy is to be applied, and that is what is the big win strategy. Before we go to that, we need to shift this strategy. A shift in the strategy is the need of the hour. Infants must be made the focus of attention for mothers, as neither a mother would like to deliver a low birth weight baby. There are so many females sitting here. I'm asking you, will you like to deliver a low birth weight baby? When you marry and you plan your pregnancy, will you like to deliver a low birth weight baby? What is your answer? Yes or no? Yes or no? Arey, जोर से बोलो. Yes or no? No, right? Nor any mother would like to have a malnourished child. Will you like to have your child suffering from malnutrition? What is your answer? No. Everybody will say, no, I want a normal child. So onus is on the parents. Onus is on the family. Only point is that the poor family, the poor mother, the poor father, maybe the grandmother, they are not aware what is to be done and how it is to be done. So I say this is the big win approach, and it has got all interventions where a lot of students are sitting here, and we will be talking about every intervention. The B is for exclusive breastfeeding for 6 months. Now, which level of prevention is this? Exclusive breastfeeding is which level of prevention? It's a primary level of prevention. Then I is for infection prevention, treatment, and immunization. If you're talking about infection prevention and immunization, which level of prevention is it? Primary prevention. Of course, treatment is again important, and you'll have to understand, if you want to have the faith of the community until and unless you treat the minor illnesses in their children, they will never have faith on you. You can't say that I am a preventive medicine doctor, for cure you go to someone else. Then the parents are not going to come back to you, right? Then G is for growth promotion and monitoring. Until and unless you weigh your child, how do you know whether the child is growing or not? And you have to catch the growth faltering, and the chances of growth faltering are maximum in the first year of life, right? From then W, of course, I have kept it because it is fitting in the acronym. Of course, it is complementary feeding. That is why we say appropriate weaning practices. Then another W is water supply, safe water supply, which is again important, because if you are providing a safe water, you are preventing all the illnesses related to the gut. And washing hand, COVID has taught us. Simple techniques. And what are these? Again, provision of safe water, washing hand. Which level of prevention is this? Primary level of prevention. Then I is for iron supplementation. There is a lot of talk, and that's a huge topic. Again, there are 2-3 lectures on my YouTube channel. If you want to study iron, then iron deficiency anemia, you can study that also. I firmly believe that, of course, we are in a habit. You see, when we don't work in the field, we don't work intensively in the field, and we try to change the goalpost now and then. Now you come out with, okay, there are hemolytic anemias, there is sickle cell anemia, there is that anemia, that is that anemia. But have you ever gone to a primary health center or a sub center? Have you ever seen the availability of iron syrup or iron tablets, whether it is uniform 24/7, 12 months? Is it available or not? If the things are not available, how it will be practiced? But iron supplementation right from the age of 4 months, as recommended by the American Academy of Pediatrics, that was IAP, that is to be done. And the dose of iron is 1 milligram per kg per day. Of course, that's a different domain. Again, if you read those, see those lectures, you will be talking about it. Then N is again important, and that is nutrition education to the mother, which is very, very important. Because you'll have to tell mother 2 things. First 6 months, give exclusive breastfeeding, followed by complementary feeding. In between, go for immunization, go for growth monitoring, maintain the hygiene, try to give safe water, wash hand every time, right? And extra nutrition in pregnancy and lactation. Extra nutrition after an illness in the child, and no to next pregnancy and no to teenage pregnancy. That is end. And that covers from mother to child all interventions which are based on primary. Now again, we'll be talking about a bit more data. Now you see again, NFHS 1 to NFHS 5, you see the exclusive breastfeeding status. It is 64% by NFHS 5. And if I ask you what is the status of hospital deliveries now, it is 89%. Before we blame others, we have to look into our own Gireban. Are we doing enough for mothers? Even in hospital delivery, if the mother is not sensitized on exclusive breastfeeding and the rate is only 64%, that tells you the story of a systematic failure. Right? Diarrheal diseases, you see, this is last 15 days, ARI, immunization. Even if you look at the immunization status, 76.4%. 76.4%. This is NFHS 5. Maybe it has increased to 80%, but still universally we are not able to do it. Those who want to know more about it, we did more than 95% coverage in our field practice area, and there is a study published in the IJCH, success story of immunization. You can find it out. You can see it, how we are able to do it. Simply giving immunization is not going to improve the immunization coverage. You will have to couple it with provision of services to the children. If you are not able to do it, you will never have faith. Then complementary feeding, look at it, 49.5%. Safe water, of course, we are very happy, 95.9%. Iron supplementation, 41.1%. Use of contraceptives, 67%. Teenage pregnancy, 7%. And anemia between 6 to 59 years of age is 67%. This is 2021. This is not my data. This is again the data of NFHS. So I am giving you a data-driven presentation, nothing personal. Personal I have already talked about. Of course, these are few success stories. I am not going into the details. This is a child who was born with a birth weight of 1.9 kg and was 11.5 kg at the end of 1 year and 10 months. Never hospitalized for any illness. These are twins with the birth weight of 1.6 and 1.7. At 2 years, they were weighing 11 kg. At 14 years, 48 kg. Now, this is a wonder child, born with birth weight of 900 grams. Was hospitalized in Safdarjung, belonged to Meerut. Came to me with a birth weight of 1000 grams. We followed it up. The child won a bronze medal in Malaysia junior badminton. The only key was that you have to keep the target in your mind that by 1 year of age, your child must be weighing 10 kilograms. And if you follow these interventions, definitely, this is again, she's getting the prize from Honorable PM Modi. So another twins, 1.5, 1.6 and 1.7. At 3 years, they are weighing 13 kilograms. So thank you so much. If you follow these interventions, every child will be dancing like this. You want to have references. These are few publications and references which we have done. Thank you so very much for giving me this opportunity. Yes, I will ask the students to go to my YouTube channel, which is in my name, Dr. Harivansh Chopra only. And you can see there are more than 100 presentations on various topics related to pediatrics and community medicine, and it will be beneficial for all of you. Thank you very much. If there are any questions, you are welcome.
Any questions? There's no question. Sir, what I would like to say is that for me, it's like a dream come true. I've always seen you on the online because I've not done my post graduation or undergraduation from UP. So I've never got a chance to attend your live lecture. So for me, it's like a dream come true. Getting learning and directly in front of you is like just a wish coming true. Thank you. And it was indeed a very good presentation, sir. Thank you.
Thank you, sir. Thank you so much. It was a wonderful presentation, and we got to learn a lot through this presentation. Thank you, sir.
Thank you so much, sir. Now I would like to request our next speaker for the day, Dr. Seema Jain, ma'am. She's an MBBS and MD in Community Medicine from LLRM Medical College, Meerut. She has 27 years of teaching experience, over 100 publications. She's the author of 3 books, co-editor, contributor to several community medicine texts. She has received 2 DM Excellence Awards and 3 Women Special Awards for community work. She was awarded State Fellowship 2022 and National Fellowship 2023. She has served as HOD in Department of Community Medicine at LLRM Medical College from 2023 to 2025 and Shubharti Medical College for 7 years. Ma'am, please begin with your speech.
Thank you so much. I'm so overwhelmed with the introduction of mine, and I'm really feeling very nervous in front of my teacher because talking after Dr. Harivansh Chopra, who's my teacher, MBBS and PG teacher, is just showing like showing a matchbox light to the sun. So, sir, please forgive me if I'm not able to, show like I'm your good student. But yes, as you have already said that the seeds of malnutrition are grown in the pregnancy. Actually, I would say the seeds of malnutrition are grown into the in a newborn girl, because before I start with my presentation, I was not formally prepared for this, but I would like to share some experiences. जैसे सर ने अपने करी, तो I would like to share because we have a extensive in LLR Medical College. I have my colleague, previous colleague, Dr. Bhavna Pant. Also, she was, we have done PG together. Then my department was also here, so we have done extensive work on maternal health and various issues we have covered. So what we have felt, if we take care of the girl child since she's born and she's an adolescent and she get married, it makes a really big impact, because nothing changes in just becoming pregnant and then giving lot many more healthcare packages. Though I am going to discuss all of them, but what is my experience is that a woman is always concerned with her mental attribute towards the health and nutrition. We are always concerned about our body image disorder, body images. So since we are born, we think that हमको एक बहुत फिट रहना है, बहुत गुड लुकिंग दिखना है, तो हमारा न्यूट्रिशन जो होता है स्टार्ट्स फ्रॉम दैट पीरियड ऑफ चाइल्डहुड कि यू हैव टू लुक लाइक अ गर्ल, और वो जो हम मिस्टेक्स करते जाते हैं वो बात तक हमारी लाइफ को इम्पैक्ट करती हैं. So this is the one thing, and another, these are my experiences which I'm sharing. The another thing which I feel is that कि अभी जितने भी हमारे प्रोग्राम्स हैं जो लेट डाउन है वो बहुत बहुत अच्छे प्रोग्राम्स हैं, और मतलब दे आर शोइंग इम्पैक्ट ऑल्सो. सर ने इतने सारे डाटा शो किए, मेरा आधा काम हो गया, बट अभी बहुत सारे जो स्टेक होल्डर्स हैं वो अभी हमने कवर नहीं करे. इफ आई टॉक कि सबसे बड़ा स्टेक होल्डर तो एक प्रेग्नेंट वुमेन का उसकी मदर लॉ होती है, उसका हस्बैंड होता है. हम FLE की, फैमिली लाइफ एजुकेशन की बात कर रहे हैं, हम प्लान पेरेंटहुड की बात कर रहे हैं, बट आई वुड आस्क मेनी गायनेकोलॉजिस्ट, हाउ मेनी ऑफ देम आर इनवाइटिंग father or mother-in-law along with the with the pregnant woman for antenatal sessions. या कितनी mothers हैं जो अपनी young girl child को समझाती हैं कि this is the way you have to take care of your reproductive organs. I have experience of in RCH more than 30 years, but I have not seen any mother talking this to her girl child. So this is very important. और मैं अपनी प्रेजेंटेशन के एंड में यही डिस्कस करना चाहूंगी कि we are thinking of गर्भ संस्कार, we are thinking of involving gynecologist in the programs, we are thinking of involving mother of a girl child, but we are not doing anything actually. Stakeholders हमें चेंज करने पड़ेंगे और हमारा पूरा गवर्नमेंट को चेंज करना पड़ेगा कि जितने भी हमारे मास मीडिया कम्युनिकेशंस काम कर रहे हैं तो दे शुड हाईलाइट द वुमेन in a way she has to be the most healthiest one. If you are thinking of a good child, healthy child, that is it. So I'll start with my presentation. Can I have, yeah. So as all we know her, like Kareena Kapoor was a uski jitna bhi pregnancy ka cover hua, it was like a big role model, और उसके दोनों बच्चों को पोर्ट्रे किया गया बहुत सारे मीडिया में. तो बट वी नेवर थॉट कि क्या चीजें उसके साथ में रही होंगी, बट वी हैव टू अंडरस्टैंड दैट जितना भी न्यूट्रिशनल स्टेटस उसको प्रेगनेंसी और ब्रेस्ट फीडिंग में मिला है, इट इज नॉट ओनली क्रिटिकल टू द मदर हेल्थ बट ऑल्सो फॉर द फ्यूचर जनरेशन. सो द न्यूट्रिशन is what she's taking in breastfeeding and in the pregnancy, but also before that. So it starts from the young age when she's born to she becomes a teenager and she follows the exercises. So during pregnancy she has definitely increased dietary requirements and support of various maternal issues and metabolism, fetal growth development. So this all has to be focused. I'm just because we have flight, but I'm covering my presentation a little bit faster. This is a very important hypothesis. This is a Barker's hypothesis in which we have it is already proven that mother health is directly related to the child's health in his or her adult age. The phenotype of child's health is there in the maternal health. So it shows a U-shaped type of a connection to whatever mother is thinking, whatever mother is having, what kind of food she's having during the pregnancy and during the breastfeeding. It is going to have impact in the child's health, not in the early age of life, but also in the adulthood. तो अगर अभी हम आज बहुत ये ट्रेंड है इंडिया में घी तेल वाला बहुत खाना खिलाना, कार्ब हाई कार्ब देना और बहुत चीनी वाला बहुत गुड़ वाला खाना देना, बट वी नेवर थिंक दैट कि माँ को तो चलो ठीक है बच्चा पैदा कर देगी एक हेल्दी बच्चा, लेकिन उस बच्चे के हम कौन से जेनेटिक कॉन्स्टिट्यूशन भी हम कॉन्स्टिट्यूट करते हैं. अरे डीएनए जो होता है वो हमको 2 ही उसके हेलिक्स दिखते हैं, बाकी जो 10 डोमेंट पड़े हुए हैं उनको हम एक्टिवेट कर रहे होते हैं. तो कि माँ को तो कभी डायबिटीज नहीं थी, बच्चों को क्यों ही, फादर को तो नहीं थी, बच्चे को क्यों, क्योंकि हमने वो जो डोमेंट जीन्स थे उसको एक्टिवेट कर दिया. दैट इज व्हाट बार्कर हाइपोथेसिस सेज. सो देयर इज अ ग्लोबल प्रेवलेंस. सर ने इसके बारे में बहुत बात कर दी है, गर्ल चाइल्ड में ज्यादा है तो हमको उस पर ध्यान देना होगा. और ये साइकिल ऑफ अंडर न्यूट्रिशन है विच सेज दैट इट इज नॉट दैट एक प्रेग्नेंट वुमेन ये नहीं है कि वो गर्ल चाइल्ड को ही करती है, इनडायरेक्टली वो मेल चाइल्ड को भी करती है. सारा हमारा जो हेल्थ है वो पूरे नेशन से उसको डिसाइड करता है कि जितने भी इंडिविजुअल्स हैं, हर बच्चे का जो एक पेरेंट है वो सबसे पहले तो मदर है जो उसको 9 months होम में रखती है. सो इट इज वेरी इंपॉर्टेंट एंड साइकिल ऑफ अंडर न्यूट्रिशन इज विशियस. सो ये मैंने बात करी थी कि इट स्टार्ट्स फ्रॉम एडोलेसेंट टू ब्रेस्ट फीडिंग, अप टू ब्रेस्ट फीडिंग एंड आफ्टर दैट ऑल्सो. अभी आपने देखा होगा कि हम लोग कई जगह लखनऊ में भी बहुत बात हो रही, गर्भ संस्कार के बारे में बात कर रहे हैं. एंड फॉर ऑल द रिलीजन इट इज बीइंग डन कि अगर मदर को जब खाना खा रहे हैं और जब भी हम रेस्ट कर रहे हैं तो वॉट एवर वी आर थिंकिंग, अगर हमारे थॉट्स में डिसीज है, हमारे थॉट्स में नेगेटिव थिंकिंग है या वायलेंस है, तो वो इट विल इम्पैक्ट द चाइल्ड हेल्थ. और आई हैव डन लॉट ऑफ स्टडीज ऑन वुमेन हेल्थ, मिडिल क्लास वुमेन and also poor women, and we have seen that believe me not, 70% of women, they suffer mental issues during the pregnancy and during rearing up their child up to 3 year of age. Physical violence ke bhi incidents 1% women ne report kare. I'm talking about the poor socioeconomic status. So how they can produce a healthy child, or we have these various programs I'll show in the next slides. This is a basket of national programs which I'm sharing. We have Suman, JS5, JSSK, बहुत सारे हैं, लक्ष्य. बट और भी प्रोग्राम्स हैं, पोषण अभियान, अनीमिया मुक्त भारत, यूनिवर्सल इम्यूनाइजेशन, सर ने भी इनके बारे में बात करी है. पर क्या ये अकेले हेल्प कर पाएंगे? एक जब हम स्केलिंग अप ऑफ मैटरनल न्यूट्रिशन की बात कर रहे हैं, कहीं ना कहीं वी हैव टू थिंक आउट ऑफ द बास्केट. And these are the various programs. What are the you see, हम कर तो रहे हैं, जैसे we take home rations we are providing, we are doing food fortification, delivery of subsidized staples are being given, but is it practically, अगर हम देखें कि we have 4 problems. I'm coming to the main point. We have 4 problems कि जो हम अपना राशन प्रोवाइड कर रहे हैं मैटरनल हेल्थ केयर पैकेज के हिसाब से, is it really going to them? उनको खुद आंगनवाड़ी के पास जाना पड़ता है, वो मोस्ट ऑफ द टाइम दे आर नॉट गोइंग. व्हेन दे आर टेकिंग इट टू द होम, वो इतना अच्छा क्वालिटी का आ रहा है. दे हैव इन आवर रिसर्च प्रोजेक्ट्स दे हैव टोल्ड कि वो खाना यूजुअली घर के सब लोग खाते हैं, बच्चे को भी खिलाते हैं. तो वो कहाँ से एक हेल्दी होगी? वो गर्भ आहार करके दिया जाता है लेकिन गर्भवती को मिलता नहीं है. एंड देयर लॉजिस्टिकल गैप्स ऑल्सो इन द सेंस कि जो फूड है वो कब तक पहुंच रहा है, या ज्यादा पहुंच रहा है तो वो वहाँ खराब हो जाता है, maybe at the food delivery points. So resources की बहुत कमी है, तो and the poor utilization. So there is a wide disparity in the access of food and the various health resources. अगर हम सिर्फ food की बात करें, so what more can be done is that we have to nationally, एक तो हमें इसको alert करना पड़ेगा, और उसके साथ साथ हमारे को ग्राउंड लेवल के सर्विस प्रोवाइडर्स को ट्रेन करना पड़ेगा, और ऐसी पॉलिसीज लानी पड़ेगी. इन द ब्रीफ आई एम सेइंग at the level of gynecologists, obstetricians, pediatricians, and every health institute, कि वहाँ पे कितना हम maternal nutrition की बात ना करके हम women health की कितनी बात कर रहे हैं. तो जब reproductive health care approach को हमने adopt करा है तो हम उसको follow क्यों नहीं कर रहे हैं? We are talking of it since 1996. बट अगर एक बस महिला अगर गर्भवती नहीं है और महिला के हाथ में बहुत छोटा दूध पिलाता बच्चा नहीं है, तो nobody is taking care of her. अगर वो पोस्ट मेनोपॉजल में या मेनोपॉजल में या पोस्ट पार्टल पीरियड में कितना ध्यान रखा जाता है, नोबडी टेक्स केयर कि उसकी थाली में क्या है. वो जब जाती है आशा, वो बच्चे को देखती है, उसको रैप करती है, और माँ का कोई आई हैव डन पर्सनली HbA1c के बहुत सारे वैल्यूएशन करे हैं, मैं घर घर जाके मैंने चेक करा है, नोबडी इज टेकिंग केयर. सो इन माई व्यू वी शुड नाउ चेंज द स्टेक होल्डर्स. बहुत दिन हो गए इन्हीं सब बातों को करते हुए. लेट्स वाइडन आवर विजन फॉर दिस. With these words, I have given my suggestions already, role of obstetricians and pediatricians. So I would like to say thank you so much because we have a flight nearby. Thank you so much. Yeah. Though I'm open to the questions.
Any questions? Sir.
Thank you, Seema, for highlighting the intergenerational cycle. Of course, I could not cover the causes of malnutrition. Would have been 4 hours lecture here on malnutrition. So it was difficult, but especially you highlighted that, and that is very, very important for everyone to understand that a low birth weight female child growing into a low weight child, and then low weight adolescent, and then becoming pregnant, and then giving birth to another low birth weight child. So that is the intergenerational cycle, which is again, it can be broken again. Actually, Point is this, that we never try to challenge the system. And you can only challenge the system if you're working in the field, you have life stories. And if you are able to do that, then you will find the things will change. Just adding on what I said, till date, we still have a policy by Indian Academy of Pediatrics that below 1.8 kg, you are not going to treat any child at home. You have to put the child in the nursery. So I gave you all those stories. So you have to challenge the system. You see, India is different. We cannot be dependent upon the data of the foreign countries. So you have to work in the field. That is very, very, very much important. And yes, implementations issues will be there, but simply blaming others is not going to solve the problem. What we have been able to contribute, that is again important. And if you can share more stories of empowering women, empowering children, and improving their health status, that becomes a stimulus, I think, for everyone sitting here who are listening to these kind of televisions. Thank you so much. So much. I think we'll have to move on.
Thank you, ma'am.
Thank you, ma'am. It was just a wonderful presentation. I would just like to add one thing in this. Like these days, most of the people are also working. Females are working. They are working women. So, sir has very well said that now even higher socioeconomic status, may we are finding malnutrition. And I guess that's the main reason behind this breastfeeding is lacking among the working females, either due to time, either due to their finding it to be because the build has changed a lot, and late pregnancies has also increased a tremendous reason behind it why breastfeeding is decreasing these days. So I just guess it should also be worked upon.
Yeah, and I suggest that we all women should, work on it. We should
Yeah.
we should strengthen the system for with the right policies. अभी भी किसी को
Policy is already there, and there is a one Dr. Hemant Joshi from Mumbai, who is a pediatrician, who fought for it, and that is why the maternity leave is increased to 6 months. So you'll have to understand the policy level is there. What is this, whether it is going to be implemented or not?
Yes, sir.
That I always say, when you organize these kind of conferences, we have deliberations for last 2 days. So what are the take home messages there? What are the simple one liner, two liners? Compile them, send it to the government of UP, government of Uttarakhand, and then see whether the changes happen or not. You will have to follow them up. That is the role of the association.
And ma'am, I think counseling of pregnant women to one, it plays a very important role because most of the nutrition part of a pregnant woman, it depends a lot on the what her family eats, what her husband eats, what her mother-in-law eats, what her children eat. So I think one-to-one counseling will definitely help with this.
we should have that much of time, but we should have.
Yes, yes. Thank you.
Thanks so much.
Thank you so much, ma'am. Since Harivansh sir and Seema ma'am have to leave early as they have their flight, so before calling our next speaker, I would like to felicitate them. So I would request Professor Dr. Medhavi Agarwal ma'am to please felicitate Professor Dr. Harivansh Chopra sir. Now I would like to request Dr. Malika ma'am to please felicitate Dr. Seema Jain ma'am. Thank you, ma'am. Thank you, sir. So, moving further, I would like to call our third speaker for the day, Dr. Shweta Jindal ma'am. She's an MBBS and MD in pediatrics from AMU, MRCPH PICU fellowship from UK, and she's an MPH from LSHTM. She's a clinician and public health specialist with publications in global journals. She has worked with UN agencies and major international development organizations. She leads the UP Health Systems Strengthening Project with Johns Hopkins University. She's an expertise in MNCH, quality improvement, workforce development, and health systems strengthening. She's the board member and guest faculty at IIHMR and Bloomberg School of Public Health. Ma'am, you can begin with your presentation now.
Good morning, everyone. And it's indeed a pleasure to be back on this stage. I would like to express my thanks to the organizing team, Dr. Bilal, and everyone here at Integral for having me back. And of course, the context has been beautifully set by my precedent speakers, Dr. Chopra and Dr. Seema. And it would have been nice it's obviously a nice opportunity to build upon what context they have set. I wasn't sure if death by PPT would be a good idea for this audience again today. So I'm just going to have an informal interaction and share my perspectives on newborn and child health and where we are at today and how we would like, importantly, the young generation of professionals in healthcare to take this. So, Dr. Chopra beautifully shared the data on newborn and child health and the causes that are contributing to it, the changes that have happened over the last 3 decades when it comes to undernutrition and newborn and child survival. Now, as has been shared about me already, I'm a pediatrician, so I did have an opportunity to work, at Aligarh and then in other places as a clinician, delivering care to newborns and children at these tertiary care centers. And what gives you that is a window into what is happening at the community level in terms of newborn and child health. And many of you, when you get a chance to be clinicians, you will also experience that. So I'm going to talk about two things here in terms of what is keeping us back in terms of enhancing our newborn and child health indicators, because the progress has been slow, as we know. Since 2014 and between 2014 and 2021, over a 7-year period, we saw a 7-point decline in newborn mortality from 21 to 14 only. And we saw a better a better decline in childhood mortality, in fact. So, what is keeping newborn mortality still stagnant? What is preventing us from making better progress in terms of reducing newborn mortality? Having worked as a care provider in newborn care units as well across many contexts in India and outside in UK, and some of very resource poor settings as well in some of the Indian states. I would like to share some common perspectives that have emerged and that can be useful for us to not only know about but also act upon when it comes to contributing our best to these. So, since now I work as a public health professional, and I work at the health systems level. I would like to share a health systems approach, which you can use to understand how we can improve the health outcomes for them. So, first and foremost, we know infrastructure is of critical importance. When it comes to infrastructure, what do we usually focus on? When we talk about newborn and child health, we focus on equipment and the availability thereof. You talk about warmers, ventilators, and all those things, phototherapy units. But let me tell you this, that the availability of equipment itself does not guarantee better health outcomes at either the facility level and then thereafter the population level. Because nowadays, with increasing investment and also emergence of the private sector, the availability of equipment is no longer as much a challenge as it used to be. However, there is a huge gap when it comes to utilization of these facilities. So, for example, you may have the most advanced stage ventilators, airway management equipment, and also breathing support units. But if you do not have the the manpower which can operate them well, if you don't have them functional at all times, then that equipment is as good as not being present. So in terms of health systems approach, having infrastructure which is not only available but also being put to adequate use is something that needs attention, and that needs interventions of the creative kind, whether it is collaboration with private sector. I did a project as well with UNICEF long back, wherein we looked at special newborn care units in Chhattisgarh. And Chhattisgarh, being a new state, it had taken great initiatives in terms of reforming its care. They had set up newborn care units at all the districts, including the southern districts, which are pretty remote and inaccessible. But the challenge that the state government found there was these newborn care units, albeit they had all the equipment that was needed for adequate newborn care, they were lying defunct. As a result, the government, what they did was they were proactive. They approached the development sector and the private sector as to, how can we operationalize these units. So what was done in that context at that time, I'm talking about 2016 to 18, what was done at that time was that an entity was brought in from the development sector itself that took over the ancillary functions for these newborn care units. And they one of the tasks that they took upon as an ancillary function was operationalization of these newborn care units. So equipment maintenance was outsourced, which meant that a biomedical engineer was placed at every newborn care unit 24/7, so that if there is equipment failure, or if people are not able to manage the equipment and or to run the equipment, they get the support that they need instantly, which translated into better newborn care at these units. So, in summary, what we understand from experiments and innovations like these is that uh, besides making infrastructure, we also have infrastructure available. We also need to ensure that the infrastructure has been put to correct use through adequately trained human resources and also adequate functioning of these. Moving on to other health system pillars, one factor that I find, one building block that I find critically important is leadership and governance. Now, why I emphasize leadership and governance is that because at the local level, at the facility level, your leadership plays a huge role. And right from your facility level to the district level, and then eventually at the state level, everything you do is determined by leadership. If you have conducive leadership, if you have leadership that supports you in new initiatives, then that makes your task easier, and that makes taking chances easier for the people who are working at the unit level. So, governance, which means putting in place new measures to ensure that the care is delivered in the way that it should be, that human resources, that your people who are working, they have the adequate support that they require, then that needs conducive leadership and governance, and therefore it cannot be overemphasized the importance thereof. Also, service delivery, we come to community level, and a lot was said by Dr. Seema about maternal nutrition. When we talk about community services, the government of India has put in place a lot of programs like home based newborn care, home based young child care, HBNC, HBYC, which many of you would know about. Also programs that have increased the institutional delivery rate, for example, Janani Suraksha Yojana or JSSK, which incentivize institutional deliveries. However, we still have a big gap when it comes to nutritional security. Food and nutrition security is something that I would urge all of you to know more about, because food security is something that is really scarce in India right now. Dr. Chopra did show some great data about even in the high and middle uh, living income group, stunting is still prevalent up to the extent of around 28%. So a third of our children, even in the high income groups, are stunted. That means that availability of food is not really a problem. What is really a problem is consistent access to it, utilization of it, and stability of it. As demographics of India are changing, we don't see the nutritional status changing accordingly. We do see a very staggered decline in terms of malnutrition, and why it is there. I'll share a very small example from my clinician days again. And there's data enough again to support it that the rise of malnutrition is highest in the age group of 6 months to 12 years. And as any of you can guess, why it happens is because breastfeeding is then needing to be supplemented by complementary feeding. That is where most children become malnourished. That is where there is room for all sorts of discrepancies to creep in into their diet. And that is where we really need to be aware of what we are doing to the nutrition environment in our society to encourage that sort of practices which are leading to malnutrition. For instance, a lot of food that is available to people these days is not nutritionally diverse. It's poor on nutrition, it is high on carbs, it has all of the ingredients which actually cause harm to children's nutrition status rather than benefiting them. Awareness is one thing, and that is where the role of healthcare providers comes in. And we can be reasonably sure that with the intent that we all come into the profession, we are doing our best to raise the awareness of parents and their families about the nutritional importance of uh, complementary feeding and what kind of food they should be giving their children. However, availability of these foods is a huge challenge, which is where the role of governments come in, and which is where we need to lobby about advocacy on things like sugar tax. Because a lot of parents, due to multiple factors, whether it's the ease of availability, ease of access, they switch to food alternatives which are not good for nutrition. For example, sugar high cereals. A lot of the families, especially which are upwardly mobile, they switch to, or they seek out these alternatives for complementary feeding. They're not great for the children. And although nutritionists and medical professionals know that, you cannot still stop families from buying them as long as they are available at an easy cost with an easy access. So food security is something that we really need to talk more about, to advocate more about, and to advocate about government and our policy makers making them harder to reach for people. Because at present what the scenario is that the nutritionally rich, nutritionally diverse foods are more and more expensive. Everything that we advise to people about feeding their children, oh, you should feed them this, you should feed them that, you should have millets in your diet, you should have ghee in your diet, you should have this in your diet. But do we ask ourselves, is that food easily accessible to those people? We talk about omega rich foods, for example, nuts and seeds. If any of you has gone and looked at the markets, are nuts and seeds available at a cost that everyone can easily afford? So these are the questions we really need to be asking ourselves, that rather than just talking about awareness and education, we also need to question, just like Dr. Chopra was saying earlier, we need to question the system. We need to question the policy makers as to the policy that are being made, are they really inclusive or not, and what are we doing about that? Then the last thing I want to talk about is, in terms of way forward, is again Dr. Seema did set the context for that, is the position of women and girls in our societies, and what role does it have to play in terms of the health outcomes of maternal and newborn and child health. We all talk about these policies, right? That okay, women should have 4 antenatal checkups, women should have institutional delivery, she should be breastfeeding, she should be taking adequate nutrition. But I don't think that we seldom really pause and think about what is really preventing that woman from doing that. Just like Dr. Chopra also asked, all of you, no mother would like to have an underweight child. No mother would like to have an undernourished child when it is when the child is more than 1 year or under 5 years of age. And if you have interacted enough, in your profession with mothers, most of them, they would know, they would be willing to act. But then our societal structures, families, and their larger ecosystems, are they giving them enough agency to act in a way that benefits their nutritional status and their children's nutritional status? When I was a pediatrician, when I was a young resident, and I would see children being brought to the ward or the emergencies in like really complicated stages of their illness, it was a very typical picture of this very sick child with a completely hassled and disenfranchised mother, and a father or other family members who know very little about what is going on with the child. And you can very well imagine why that scenario is created, because that mother who knows everything about her child's health and nutrition, she is, in most such cases, does not have the agency and the ability to access care when it is most important. सो एंड ऐसा नहीं है कि उसे पता नहीं है कि मेरा बच्चा बीमार है या मुझे उसको कहाँ लेकर के जाना चाहिए, बट डज शी हैव द मनी, डज शी हैव द मोबिलिटी, डज शी इवन हैव द rights given to her by the family that she can take her child, she can ask the questions. So these are questions, these are tough questions that we need to be asking, not only to the system but also within ourselves, and to always not put the onus on that single entity which is called the mother, who is to be held responsible for her own health, for the newborn's health, for also the child health. If anything goes wrong, all the fingers are pointed at the mother, but nobody looks at the system in which that mother is surviving and trying to do her best for the child. So that is again on the speaking on the social social side of mother, newborn, and child health. But coming back to health systems, there is still a lot to be done. We need to take a comprehensive approach to look at. I would really encourage us all to take a health systems approach, to not just look at it from a very problem focused approach कि अच्छा ये नहीं है तो इसको ठीक कर देते हैं, but then you also have to put on the think of a hat of a problem solver, and identify bottlenecks when they're arising, and then act in a way wherein problems are taken care of before they arise. And that is my short message to everybody present here. A lot of technical and data related details have already been talked about, so I'm glad that the context was set beautifully, and I have a last message to give. So that's all from my side. Thank you.
Any questions, please? Thank you, ma'am. It was indeed a wonderful presentation. We really enjoyed. Thank you.
Thank you so much, ma'am. Now I would like to request Professor Dr. Medhavi Agarwal, ma'am, to please felicitate our speaker, Dr. Shweta Jindal, ma'am. We are done. With this, we end the second session of today. Okay, so moving forward to the third session for today, which is on the topic non-communicable disease. Non-communicable diseases such as the heart disease, diabetes, cancers, and chronic respiratory diseases are now the leading causes of sickness and premature death in India. Driven by tobacco use, unhealthy diets, lack of physical activity, air pollution, and rising stress, Non communicable diseases affect people across all ages and communities. Their impact goes far beyond health, creating heavy social and economic burdens on families and the healthcare system. Effective action requires prevention, early screening, strengthening the primary health system, and the multi-sectoral collaboration. As we begin today's discussions, let us remember that tackling non communicable diseases is essential not only for saving lives, but for ensuring a healthier, more productive future for our society. So, the first chairperson for this session, we have Professor Dr. Reema Kumari ma'am. She's professor in community medicine and public health at KGMU Lucknow. She's an MBBS and MD from KGMU. She has 23 plus years of teaching experience, guided numerous MD and PhD theses. She has 68 plus publications and involvement in 17 plus research projects. She's contributed to several book chapters, including Holistic IVF, IUI, and Garb Sanskar. Thank you so much, ma'am. Our next chairperson for the day is Dr. Vishal Parmar sir, Head of Department of General Medicine. And the third chairperson for this session is Dr. Mukhtar Ahmed, Associate Professor in the Department of General Medicine. Before beginning this session, we would like to felicitate the chairpersons of our last session. So I would request Dr. Vishal Parmar sir to please felicitate our chairperson for the previous session, Professor Dr. Medhavi Agrawal ma'am. Now I would like to request Dr. Mukhtar sir to please felicitate our chairperson, Dr. Malika ma'am. So moving forward for this session, the first speaker for this session, we have Dr. Mohammad Tausif Khan sir, who is an assistant professor in the Department of Medicine at Integral Institute of Medical Sciences and Research. He holds an MBBS and MD in medicine, along with fellowships in diabetology and in prevention and management of diabetes and cardiovascular diseases. With clinical experience at RML Hospital and Charak Hospital, he has contributed significantly to patient care, medical teaching, and institutional care. He has secured an intramural research grant and has presented multiple e-posters at prestigious national and international conferences including EASD, ATTD, Diabetes India, ECIM, and APICON. His research interests include diabetes management, Ramadan fasting physiology, and infectious diseases profiles. You can begin with your speech, sir.
A very good afternoon to our respected dignitaries, HOD sir, Mukhtar sir, ma'am, for giving me an opportunity to speak on non-communicable diseases. Since it's a conference about the community medicine and I am being from the Department of Medicine, so today we will not talk about the treatment part and the pathogenesis and all that. Rather, we will discuss how being from the Department of Medicine, we can contribute in treating the non-communicable diseases. Non-communicable diseases remains one of the most silent yet powerful risk factors confronting the modern medicine. And hypertension is called as the silent killer, not because it cannot be treated and not because it cannot be detected, but because it continues to be a leading cause of cardiovascular morbidity and mortality worldwide. And so that's why I have given this title like Hypertension, a Turbulent Rage. And we will be discussing why it deserves attention, urgent attention, and how, as an healthcare professionals, strengthen our strategies to combat it. So, if we discuss the global epidemiology, it corresponds about 1.28 billion adults aged between 30 to 79 years have hypertension, and the control rates remain low globally, often less than 25%, and it contributes to more than 10 million deaths annually. The prevalence in adults is 29% as according to the ICMR and India Society for Diabetes, NFHS, and national surveys. The urban prevalence is 30 to 35%, while the rural prevalence and is 25 to 28, and the awareness is still a 50, approximately up to 50%. And out of it, 40% are diagnosed, and only 18 to 20% are controlled. The high prevalence is seen at the age of more than 40 years and in urban slums and socio-economically stressed households. The lifestyle transition like salt, stress, obesity are the driving rise. Public health importance. Hypertension is the leading modifiable risk factor for cardiovascular diseases, and it contributes significantly to the coronary artery diseases, stroke, chronic kidney diseases, heart failure. Now, the rule of halves. Now, only half of the hypertensives know. Why it is called as the rule of halves? Just because only half of the hypertensives know they have it, and half of diagnosed patients receive treatment, and only half of treated achieve adequate control. And it's a major drive for catastrophic health expenditure, will reduce productivity and long-term disability. Now, it is a chart showing the blood pressure ranges, and in a normal healthy individual the normal blood pressure is between 120 systolic and 80-degree diastolic, with a rise elevated blood pressure ranging from 120 to 129 and less than 188, and stage 1 hypertension is 130 to 139, and range for the diastolic is 80 to 89, and stage 2 hypertension is 140 or higher, or 90 diastolic higher. The hypertensive crisis is blood pressure more than 180 mm of Hg systolic and 120 more than 120 diastolic. Now, the why the out of it the most important thing. Now, as we talk about hypertension, we talk about hypertension, and the most common thing that we encounter is how to measure it. So there has to be an adequate system. There's an adequate protocol that we should follow before measuring the blood pressure of any of the patient that comes to our OPD, because that's only the readings will decide will the patient be needing a lifestyle modification, or will the patient be needing the treatment. So the first thing is the wrong cuff size. The patient coming to the OPD should be given an the deserved cuff size. It should not be small, because if you give a small cuff to the patient, it will give a falsely high BP blood pressure readings, and a large cuff gives the falsely low blood pressure readings. The arm should be at the arm, not at the heart level. The arm should be at the heart level, because hanging arm raises blood pressure, and a lifted arm lowers it. Patient should be asked to rest, should make herself calm and composed. A talking patient, a stressed out patient, an anxious patient always gives a false reading for blood pressure, and again the patient will be misdiagnosed. The patient should not have any recent intake of coffee or tea, and the patient should not be having a full bladder. The bladder should be emptied. We should ask the patient whether he wants to have urge for the micturition, because the bladder should be empty, and full bladder pushes the blood pressure up to 5 to 15 millimeter of mercury, and again giving the false reading for the blood pressure. Cross legs or unsupported back or feet again falsely elevates the reading. So these are the prerequisites which are not complicated but should be taken into consideration before we take the blood pressure for the patient. So this is how should the patient should be sitting. Front flat on the feet should be flat on the floor, back to be supported. There should be no talking in between the measurements. Cuff size should be of the arm size, and the arm should be rested on the table. So there are again risk factors, non-modifiable determinants like age, family history, genetic predisposition. Males are more predisposed for hypertension as compared to women, while postmenopausal state in the women is also the non-modifiable risk factors. The modifiable risk factor is the excessive dietary salt intake. The national average intake should be 9 to 12 milligram per day. It should be less than. It should be less than. Obesity, particularly abdominal and central, physical inactivity, alcohol excess, chronic stress, the long working hours, tobacco, nicotine induces the sympathetic activation. Although there are socio-environmental determinants also, like urban density, the sedentary transport, the fast food availability, the air pollution, socioeconomic status, access to care and diet patterns, education like health literacy and adherence. High salt consumption, like behavioral risk factors, high salt consumption through packaged food, pickles, snacks, low fruit and vegetable intake, high refined carbohydrate should be the low fiber diets. Alcohol binge pattern is most common in males. The sedentary lifestyle is also a contributing factor, like physical activity of less than 150 minutes per week. Stressogenic environments like now noise, crowding, job strains, cultural habits like added salt at the table, high salt traditional foods, poor sleep hygiene, and shift work patterns. The hypertension is also known as a lifestyle disease, where this is a triad, this is a pyramid showing the agent, like no specific, there's no specific organism in it. The agent is the lifestyle stress environment, and the host is the person having the genetic susceptibility, age of more than 40 years, the obesity, the metabolic syndrome. Environment is the urbanization, air pollution, processed food industry, tobacco, alcohol availability. Like as the speaker, ma'am, before me has rightly said, system. She talked about the system. It's not only the mother that is responsible for everything. The system has to be asked. So this environment, the environment in which the person is living, like in an urban lifestyle with polluted air, the processed food industry, this is tobacco and alcohol availability. These are the environmental factors that are also the contributing for the hypertension. Now the levels of prevention. Now there's a primordial prevention. There's prevent the emergence of the risk factors, and the primary prevention is the prevent onset of disease in high risk or general population. Well, in the secondary prevention is the early detection, screening, and prompt management. Tertiary is again the last, the prevent complications and disability, and each level has specific community behavioral and policy strategies. Now, in the primordial prevention, we have to create environments that promote the health choices, healthy health choices, the salt reduction at population level, regulation of the trans fat and saturated fat in processed food, calorie labeling in restaurants. Like in hypertensive patients, we advise the DASH diet, DASH. That's the dietary approach to stop hypertension. Now, the motive of this advising the DASH diet is to reduce the blood pressure by modifying the eatery habits of the patient. What we advise is the we advise the more intake of fruits which are high in potassium, we ask the patient to restrict the salt intake. We ask the patient to reduce the intake of trans fats. We ask the patient to promote to have more green leafy vegetables in the diet. So these are all the factors that helps us in regulating the blood pressure at the primordial stage. Now, the urban planning, like walkable cities, cycling, public transport, obviously, the life has become easier with everything, with the luxury we have. And that's why the incidence is also rising. The physical activity, the public transport, now we have cars and everything. We barely walk on foot. We barely walk on foot. So these are also the risk factors for developing the hypertension. School-based interventions like healthy canteens should be there. Healthy food, not all those chola baturas and bread pakoras. And I used to have it. So these menus should be checked, and the healthy menus should be introduced into the school-based canteens. The daily physical activity should be increased. Mass communication promoting the low salt diets, controlling aggressive marketing of unhealthy foods to the children. Lifestyle modification is the cornerstone of prevention. है ना? The salt is less than should be less than 5 grams per day. Weight reduction is there at increase of 5 to 10% reduction in 10% of the weight reduction in the body weight leads to the 5 to 10% decrease in the blood pressure substantially. Regular aerobic activity of more than 150 minutes per week. The WHO recommendation is 150 to 300 minutes per week, and more than 2 days of strength training in a gym. So if someone is going for the aerobic activity, it's 150 to 300 minutes a week, and if someone is going for the strength training, it's 2 days a week. Avoid tobacco and limit alcohol. The dietary approaches, DASH type, like high fruits, vegetables, whole grains. Stress reduction, yoga, meditation, workplace redesign, community awareness campaigns through ASHA workers, NGOs, work site health programs, blood pressure checkups, and activity breaks. So this is the impact of lifestyle modification. The modification, if you go for the weight loss, if you advise the patient to have a weight loss, and of having a patient of a metabolic syndrome, of patient having obesity, so the target BMI is between 18.5 to 24.5. So this is marked decrement in the blood pressure of 5 to 20 mm of Hg. That is approximately, if a patient loses 10 kg, so the reduction in the blood pressure. The DASH diet. So DASH diet contributes to 8 to 40 millimeter of mercury. The sodium intake should be less than 6 gram a day. Again, alcohol intake. If we control the alcohol intake, so there's a reduction in the blood pressure. Exercise. The dynamic exercise, aerobic exercise, 30 minutes a day. Dynamic exercise, 90 to 150 minutes a week. And isometric hand grip. So this goes for the strength trainings and other things. The reduction is 5 to 10 mm of Hg. Mindfulness, meditation, and breathing control again contributes to the 5 millimeter mercury reduction in the blood pressure. Now, the secondary prevention leads to the screening and early detection. Now, the patient has come for the screening, and we have to detect it at the right time. So, opportunistic screening in all adults of more than 18 years, and more frequently screened for the diabetes, obesity, chronic kidney disease, and a family history of any premature cardiovascular disease. So these are all the risk factors, and if the patient is having any history of this, it should be screened for it. So methods, these are the methods by which we can take the blood pressure at our home, also at our offices, or in the OPDs, like manual BP measurement using standardized protocol, automated digital devices for mass screening, and out of office blood pressure monitoring, home and ambulatory blood pressure monitoring. And the follow-up, it should be linked to the screen individuals to NCD clinics, health and wellness centers for monitoring, digital tools for reminders and others. We have apps these days which alert us about a heart rate. Now, the for the tertiary prevention is the long-term control and complications in prevention, ensuring adherence to the medications. Now, the patients already have the disease. Now the compliance is important. In OPD, we encounter patients like who are non-compliant to the medications, and sometimes because of their financial conditions is also a risk factor. Why? That's why they're not able to follow it properly. Controlling other risk factors like diabetes, dyslipidemia, smoking, thereby preventing the stroke, chronic kidney progression, heart failure, hypertensive emergencies, rehabilitation post MI patients, post stroke physiotherapy, counseling for lifelong behavioral changes. So, family level education to support patient adherence. So this after everything has been done, so if the patient finally he has the blood pressure, so for the treatment part, we give the thiazide group of diuretics initially, along with the combination of ACE and ARBs based on the other clinical parameters. There should be no how to prevent it at an early stage. That's the point. The point is the problem should be nipped in the bud. So that's why there should be mass screening camps at village, at melas and urban clinics, opportunistic screening in OPDs, pharmacies, workplaces, like we have celebrated World Diabetes Day yesterday. So it is so screening programs like this helps us to detect the patients at an early stage. Targeted screening should be for the elderly, diabetics, chronic kidney disease patients, and technology enabled telemedicine follow up apps to track BP readings, electronic health records. Community worker involvement should be is very important, like ASHA workers for home visits and referral, ANM blood pressure measurements in this subcenter. Social and cultural barrier. There are some cultural barriers in the villages, like BP tablets cause dependence. मरीज कहता है डॉक्टर साहब एक बार दवा शुरू कर दी जिंदगी भर खानी पड़ेगी. And same goes for the insulin also. एक बार इंसुलिन लगा दी हम इसके आदी तो नहीं हो जाएंगे. Though he's taking nicotine since last 20 years, he's not bothered about that. But he's more bothered, like if you take the insulin or BP medication, will be dependent on that. This is a common myth. Irregular medication due to cost or side effects. Preference for traditional salt-rich foods, and like in Punjabis, we have more lacking for chola bhaturas and other things. So cultural acceptance of obesity, healthy and strong, like in villages or in cities also, there's a myth like कि अरे दुबले हुए जा रहे हो, थोड़ा मोटे रहो, थोड़ा सा ताकत रहेगी. So these are all the wrong myths prevalent in the society. Stigma around the chronic disease, low priority given to the asymptomatic illness. Now, hypertension is why hypertension is a silent killer, because in many of the patients, like if there are two categories basically for hypertension, like essential hypertension and a secondary hypertension. Essential hypertension contributes mostly to 80 to 95% of the patients, and it is more dangerous because the symptoms are not there. The patient is walking asymptomatically and is not feeling anything, so he's not coming to the OPDs, he's not going to the doctor. While secondary and then the patient in secondary hypertension, the patient has symptoms, or it has an etiology for which he is having hypertension, like for chronic kidney diseases, for the stroke, and for the diabetes. So low priority given to the asymptomatic illness. Family pressure in the dietary habits. Health education strategies, and that has been there. The community talks, group sessions have been organized, street plates have been organized. I see material like posters, leaflets, local language videos, television and radio messaging, counseling for the high risk patients, engaging community leaders, teachers, employees, addressing myths and conception, demonstrating correct BP measurement and technique. The last line is very important. It's very important. All those students who are here, please note the correct way of BP measurement techniques. Now we have national programs for this hypertension also. National Program for Prevention and Control of NCDs. So it's a population-based screening for hypertension with regular follow-up through health and wellness centers, NCD clinics at CHC and district health levels. Free or low-cost essential medicines training of ASHA, ANM, and multi-purpose workers. Ayushman Bharat Health and Wellness Centers is also there, which runs its telemedicine OPDs. Like other supportive frameworks are also there: Fit India movement, Eat Right India, national multi-sectoral action plans for the non-communicable diseases. Challenges in India are the low awareness and late diagnosis, lack of standardized BP measurement practices, medication non-adherence for the cost, fear, and misconceptions, overburdened primary healthcare system, rural-urban disparity, cultural dietary patterns, fragmented follow-up, and limited integration of digital tools across states. Now the conclusion is hypertension is still not easy. Hypertension is a major public health challenge, and PSM approach essentially is prevention at every level. Population strategies is there, strong primary care, community engagement is fundamental, and policy changes need for sustainable progress. Now, at last, I just want to conclude it by saying that this hypertension is a lifestyle disease, and it's becoming the new epidemic. So it stands at the center as a silent killer. It is preventable, manageable, but still neglected. As a healthcare professional, we had the power to change it. We have the power to identify it early and treat it dramatically. Thank you.
Thank you so much for your presentation. I think you have covered all the levels of prevention, primary, secondary, tertiary. And the one thing most important, you have covered not only the community medicine aspect, but also the medicine aspect, how to take the blood pressure, what points should be kept in mind. We usually do the mistakes. So this is the good learning experience for the students also. And one thing I would like to say, as we all know, hypertension is a lifestyle diseases. So there should be holistic approach. What you have covered, I think, every approach. The holistic approach means physically, mentally, socially, and emotionally. That is what means spiritually also. Unless until we will not treat our stress level, why stress level is there, what are the factors contributing to stress level, then only we can keep ourselves normal balance. So thank you so much for your
Thank you, ma'am. Thank you so much.
Thank you so much, sir. Now I would like to invite our next speaker for this session, Dr. Nida Khan ma'am from Department of Internal Medicine, Integral Institute of Medical Sciences and Research. She has contributed to outbreak mathematical modeling in collaboration with the SCOL Foundation, combining clinical insight with analytical methods to strengthen epidemic forecasting and public health preparedness. You're welcome, ma'am. You can begin with the session.
Thank you. A very good afternoon to the respected chairpersons, dignitaries, faculty members, students. So, as rightly said before also, non-communicable diseases are a global burden, and diabetes is one of the fastest growing health challenges that we are facing today. Diabetes affects millions of people worldwide, but yet often misunderstood and diagnosed very late. So let's see the signs of diabetes prevention. So first of all, what is diabetes mellitus? It's referred to a group of common metabolic disorders that share the phenotype of hyperglycemia. And depending on the etiology, what are the factors that contribute to hyperglycemia? They include reduced insulin secretion, decreased glucose utilization, or increased glucose production. So, diabetes is the leading cause of end-stage renal disease, non-traumatic lower extremity amputations, adult blindness, increased risk for cardiovascular disease, which is the main cause of mortality and morbidity in this population. So the diabetes cases are increasing day by day. Approximately 589 million adults between the age of 20 to 79 years of age, they are living with diabetes. Of those adults with diabetes, around 252 million are estimated to be undiagnosed. And the prevalence of both type 1 and type 2 is increasing worldwide, but the prevalence of type 2 is rising more rapidly because of dietary changes and the increasing obesity and reduced activity levels. And the number of adults with diabetes is projected to rise to 853 million by 2050. So, diabetes was responsible for more than 3.4 million deaths in 2024. And the countries with the greatest number of individuals with diabetes in 2019 were China, 116.4 million, India, 77 million, and US, 31 million. So, diabetes is a major cause of mortality. In recent years, diabetes has been listed as the seventh leading cause of death in the United States. So, screening for diabetes that occurs across the lifespan. It's better to pick up at the very early stage, that is in utero, because early life is a lifelong impact. So, IUGR babies have the major risk of uh, developing into type 2 diabetes later in life. So, if we pick up diabetes in IUGR babies, we can monitor them. We can monitor them closely. Why the reason IUGR babies develop type 2 diabetes mellitus? Because of the fetal womb gets decreased nutrition, so the body doesn't get a good supply. All the needs are directed to the brain. So through that fetal programming and thrifty phenomena, the IUGR babies tend to develop pancreas underdevelop and their beta cell function decline. So they develop diabetes later in their life. So the clinical implication, if we identify IGR infants, we enable targeted monitoring throughout childhood and implementation of preventive strategies to mitigate further diabetes risk. Then pediatric screening. If we type 1 diabetes are not routinely screened because of the limited resources, but if there are family history or autoimmune antibodies are present, then we have to screen type 1 also. And type 2 diabetes, if their BMI is more than 85 percentile and there's a family history of type 2 and there are signs of insulin resistance like acanthosis nigricans, then we have to diagnose these patients. And if the maternal gestational diabetes was there, we have to diagnose type 2 because of the increasing obesity in pediatric age group. And we then from the pediatric, we have to screen the adults also. So we consider testing in overweight or obese patient or those who have the risk factors and family history of diabetes. If the race and ethnicity, example African, and hypertensive in BP more than 140 by 90, and HDL cholesterol level less than 35, and triglyceride level more than 250 milligram per dl, polycystic ovarian disease or history of cardiovascular disease, yeah, history of physical inactivity, and other conditions which are associated with insulin resistance like severe obesity and acanthosis nigricans. And in individuals in which previously identified have impaired fasting glucose, impaired glucose tolerance, and HbA1c 5.7 to 6.4%, they should be screened annually. And women who had gestational diabetes mellitus in their pregnancy, they should be screened at least every 3 years. Most of them, after they get over with their pregnancy, they just leave it, and that develop into over diabetes. And when they are diagnosed, that gets very late. So they should also be screened every 3 years. And for other individuals, initiate testing at 45 years of age and repeat every 3 years, and individuals with HIV. What are the preventive strategies for diabetes? What are the guidelines for ongoing comprehensive medical care for individual with diabetes? In individualized glycemic goals and therapeutic plan, we individualized in them. Self-monitoring at individualized frequency of blood glucose or interstitial glucose and HbA1c testing should be done 2 to 4 times per year. Lifestyle management in the care of diabetes and diabetes self-management, education and support like nutrition therapy should be given to them, physical activity should be counseled, and psychosocial care is a very important factor in them. Like we have to evaluate for depression and anxiety in these patients. That should be taken special care of. And detection, prevention or management of diabetes related complications so that they don't further develop complications because of diabetes, like diabetes related eye examination, as we very know that it affects every organ. So annual or biannual examination should be done. Diabetes related foot examination 1 to 2 times per year by provider and daily by the patient. And diabetes related neuropathy examination should be done annually, and diabetes related kidney disease testing should be done annually. We have to manage or treat relevant conditions like hypertension. Blood pressure should be monitored at least 2 times per year. Lipid should be monitored 1 to 2 times per year. And we have to consider antiplatelet therapy with low dose aspirin. And they should also be considered for immunization like influenza, pneumococcal, Hep B, and that all should be covered in them. So what is it? How we will once the patient has already developed diabetes, how we will treat them? So type 1 diabetes is treated with insulin. We intensive insulin therapy we give to reach normoglycemia. So we have two types of insulin, like short insulin, long-acting insulin. Short-acting is lispro-asparagine, and large one, long-acting is glargine, detamir, degludec. But the most important thing is we have to tell a patient how to administer insulin. If patient doesn't know the right technique, it'll everything will fail. So we also have to tell the patients in OPD how to properly inject the insulin, how to, for how long we have to inject the insulin. Everything has to be properly explained to the patient. There comes the role of a physician. And we initiate insulin, the type 1 needed at the dose of 0.3 to 0.7 units per kg per day. And we initiate in like basal bolus can be given. Like we also give as a basal dose, and mixed also. But basal bolus is the preferred one because that mimics the physiological action of insulin. And for covering the type 2, we give oral hypoglycemic agents. We have so many like insulin secretagogues, insulin sensitizers, like metformin is the most common drug we give, sulfonylureas, TPP4, GLP-1 analogs, and SGLT2 inhibitors, so many that we, according to the patient, we decide the treatment. So the thing is we have to address the problem. We have to prevent it. Diabetes is a silent epidemic, but is largely preventable if proper actions and awareness and everything is done on time. So we have to, firstly screen right from the neonatal age to the adult age, and we have to properly screen them. That's how we can prevent it. Thank you so much.
Hello. Hello, Dr. Nida. You have presented very well about diabetes mellitus.
Thanks.
Actually, and you also mentioned about the low weight child prone to the type 2 diabetes mellitus. Actually, malnutrition include not only undernutrition. Whenever we say the malnutrition, it is undernutrition and overnutrition. And the diabetes mellitus is also related to undernutrition in the childhood and overnutrition also in the childhood and adulthood. That's why nutrition is very well in the prevention of the diabetes mellitus. Thank you very much.
Thank you so much.
Thank you so much, ma'am, for an insightful session. Now we'll move forward for the felicitation. I would like to request Professor Dr. Reema Kumari ma'am to please felicitate our first speaker, Dr. Tausif Khan sir. Now I would like to request Dr. Vishal Parmar sir to please felicitate our second speaker, Dr. Nida Khan ma'am. Now I would like to request Dr. Neeti Verma ma'am to please felicitate our esteemed chairperson, Professor Dr. Reema Kumari ma'am. Now I would like to request Dr. Malika ma'am to please felicitate our esteemed chairperson, Dr. Vishal Parmar sir. Now I would like to request Dr. Syed Fiza ma'am to please felicitate our esteemed chairperson, Dr. Mukhtar sir. Thank you so much, everyone. With this, we end the third session for the day, and now we'll gather here again for award distribution in a short while. Thank you.